inter-academy joint meeting. I am sure that this is a hallmark of the scientific interaction of different academies of medicine in a moment where the entire world is suffering such a grand challenge. This meeting, as everybody I think is already aware of, has been organized by our academy and the UK Academy of Medical Science. As a matter of fact, we have a sort of long-standing interaction with the UK Academy of Medical Sciences in the organization of very successful meetings. We just, in the beginning of this year, we jointly organized a meeting in urban health, which is absolutely related with the pandemic that is occurring now. And at that moment, one of the hallmarks of the meeting was the absolute necessity of obeying scientific evidences in the way that a pandemic like this one that we are suffering now has to be coped with. You know? And here in Brazil, at this exact moment, we are suffering an additional crisis within the crisis when our Ministry of Health and other government officials are still discussing the way that the social isolation should be conducted. And the Ministry of Health, which has our, which is a very important figure in stressing the importance of obeying scientific rules and scientific evidences in the conduction of the crisis and on the conduction of the social isolation, is being sort of is having his position sort of discussed, and his ideas are not accepted by everybody within the central government. So we are really living, as I said, a crisis within the crisis. And in this very moment, a meeting such as this one that we are organizing and that is beginning now is of the utmost importance to show what are the ways of conducting the policies that will permit us to surpass the present moment. So I thank everybody that is present here. I thank very much the people from the UK Academy of Medical Sciences. I thank also, of course, the people at our academy that were involved in the organization of the meeting. And I'm sure that the meeting will be a great success. Thank you very much.
So I think it's now for me to say hello, Alex.
Yes, yes, please do.
Okay, so I'd like to introduce myself. I'm Anne Johnson. I'm the Vice President International of the Academy of Medical Sciences. Absolutely delighted to be joining this meeting today and for the close accord between our two academies in preparing this meeting. Just to say, we have been working together as two academies over a number of years and months, and recently we've had several meetings together. We are the UK's National Academy for Medical Sciences. We have something like over 1,000 elected fellows across the full spectrum of basic biomedical and clinical and public health research. And we recognise the enormous importance of reaching out to our colleagues around the world in dealing with this appalling pandemic which affects all our societies and all our people. That we try to promote medical science and to translate benefits into society. And I think never have we seen such a challenge which faces us together to work together in multidisciplinary ways to deal with this public health challenge. We try as our academy to promote excellence to its research and policy, and we see nothing more important than the relationships with other national academies around the world in working together. And so we are so delighted that your president has reached out to us along with us in the academy, Marcelo here, to work together in discussing our responses to the COVID-19 pandemic. What we hope to do, as I'm sure you've heard, and I'm sorry I joined slightly late, I had a technical problem, but to say that the objectives of the meeting are to share evidence and learning from our two countries. And as our country is facing the biggest epidemic anywhere in the world, we are now the epicenter of the epidemic in Europe, and in Europe, and we have facing big problems in the UK. And as your country is somewhat behind us in terms of the epidemic, we thought it was important to try to share our experiences together in the field of public health response, in the field of clinical response, and in the field of laboratory response. And we are looking very much to our interactions today.
Thank you very much. Well, first of all, on behalf of the National Academy of Medicine in Brazil, I want to welcome you all, and since the beginning express our appreciation to our colleagues from United Kingdom that responded to our initial request since the beginning with great efficiency and courtesy. I believe all of that was because the special relationship that Brazil and the United Kingdom have established through our academician Marcelo Barcinski and others. No doubt that we are challenged the most important medical problem in the last 100 years, and it's very important that we interact and we try to share our experience and discuss our common challenges. This meeting is very important, and tomorrow a joint statement will be issued by both academies addressing some important problems that we believe the whole society in our countries should be informed about. Just to give you some house details, we are now with over 70 people in this Zoom platform, and this meeting is also being broadcasted through Facebook in Brazil and in England. We have invited academies of medicine of different countries of Latin America, and I am very well impressed by the quick and efficient response we receive from many countries. I'm not going to be able to list all the names, but I want at least to announce you that we have with us people from the Academy of Medicine of Colombia, Paraguay, Bolivia, Argentina, Costa Rica, Uruguay, Chile, and Venezuela. We also have the pleasure of having here representatives from Spain that is also a member of this network of academies of medicine. We have also people from state academies of medicine in Brazil, including Bahia, Maranhão, Amazonas, and Ceará. We are doing this in partnership with the Brazilian Academy of Sciences, the Brazilian Academy of Pharmacy, as well as the Brazilian Medical Association that are our partners. And we're very proud of it. The idea is in the next weeks to organize something that would be directed to Latin America, and we plan to have every country of Latin America present in the meeting and discussing the local problems and again trying to issue a joint declaration. As Professor Ann Johnson said, Brazil is behind the epidemic, and some countries in Latin America are, thanks God, even further behind than Brazil. And it's very important that we learn from the experience in Europe and other people learn from our experience in order to minimize all the tragedy of this. I want also to express my, again, my sincere thanks to the United Kingdom Academy of Medical Sciences for everything they have done to help us organize this meeting. We are, as I said, very proud of it. And regarding Latin America, also I have to mention the academician José Augusto Messias, that in charge of this relationship on behalf of our academy, for the excellent work that has been done. We want now to go ahead with the program, and we would like first to ask Professor Ann Johnson to introduce the next speakers that will discuss the public health aspects of the pandemic in the United Kingdom first, and after Professor Edelstein, Professor Mauricio Barreto will follow him. Mauricio Barreto is an old friend, is one of the most important epidemiologists from Brazil, from Latin America. He has worked for many, many years in chronic disease, had a pivotal role during the Zika outbreak, and he's very active right now in coronavirus. I want to express my gratitude also to Professor Mauricio Barreto for accepting our invitation. Mauricio Barreto is also a member of Brazilian Academy of Sciences. Anne, would you go ahead, please?
Yeah. Thank you very much, Professor Belfort. I'm delighted to introduce Dr. Michael Edelstein. Dr. Edelstein is an infectious disease epidemiologist and a public health physician. He works with Public Health England, which is our national public health agency, and has been closely involved with the surveillance and public health response in relation to the COVID-19 epidemic in the UK. And he also has worked with a number of international agencies and with Chatham House organisation in the UK. I would like just to remind the speakers that we have strictly 15 minutes in each speaker, so that we have time for discussion after each of the sessions on the different topics. And if I could please ask the UK speakers, I hope you will forgive us that we are not speaking to you in Portuguese, and I'm sorry that we have to run all this entirely in English, but I hope that we can ask the English speakers to ensure that they speak clearly and relatively slowly for those who do not have English as a first language. So without further more ado, I will like to pass over to Dr. Edelstein to give his presentation. Michael.
Thank you very much. Thanks, Anne. Can everyone hear me?
Yes.
Yes,
Yes,
perfect. Well, first of all, it's a real pleasure to speak today and to collaborate with colleagues across the world, really fighting this common pandemic that is the COVID-19 pandemic. Since I have the privilege of having the first presentation, I thought it would be useful to run an overview, not solely focus on the UK, but to run an overview of the outbreak and hopefully share with you the importance of early implementation of public health measures in order to mitigate the consequences of this outbreak. For those of us who are involved in the day-to-day management of the COVID-19 pandemic, it can very much feel like this has been going on forever, but actually it's only been about 3 months, and in many parts of the world, less than that. And I thought it would be useful to start by running through a very quick timeline and some of the milestones that we've been through as part of this outbreak, because I think it illustrates the speed and the magnitude of spread and how quickly the situation had escalated, fueled by the volume and speed of international travel. So if we go back to late December of last year, on the 31st of December, China reported a cluster of pneumonia of unknown origin in Wuhan, and very quickly a novel coronavirus was identified. About 2 weeks later, mid-January, the first case was reported outside of China, and that was in Thailand. About a week after that, the city of Wuhan, a city of 11 million people, was placed under complete lockdown. And a week later, there were 9,000 cases outside of China. So this is two and a half months ago, there were only 9,000 cases. We're now over 2 million. 2 weeks after that, in mid-February, there were only 3 deaths outside of China. And at the end of February, the first case was reported in Brazil. A few days later, by early March, barely a month ago, there were 100,000 cases worldwide. And 2 days later, on the 8th of March, Italy declared a lockdown of some of its northern regions, which seems like a long time ago now that virtually all of Europe is under lockdown. And 3 days later, after a long delay, the World Health Organization declared COVID-19 a pandemic. And if we fast forward to yesterday, we're up to 2 million cases, 135,000 deaths, and over half of the world's population under lockdown. All this in less than 3 months, and caused by a virus that is neither particularly lethal or infectious compared with other viruses that we know about. So I think it's an important lesson to keep in mind for now, but also for after this pandemic, to understand what it means and how things could play if we had a virus that was even more transmissible or more lethal. These figures are quite impressive, but if we dig down and look at different countries and how the outbreak has played out in different parts of the world, we see different scenarios that have played out. The first group of countries that I'd like to focus on very briefly is some of the Asian countries that were first affected: Hong Kong, Singapore, South Korea. And interestingly, they managed, by acting very early and very stringently, to keep their number of cases relatively low. And as a result of that, they've managed to avoid lockdowns on the scale that we've seen in Europe. Having said that, they may be seeing the beginning of a surge. In contrast to the picture that we've seen in those countries, in Europe, most European countries, in North America, what we've seen is a slightly later increase in cases, but a very large and very rapid increase in the number of reported cases and in the number of deaths. And this increase has been followed by restrictions on movement and the imposition of social distancing. And these were implemented at different times if you look at the timeline of the outbreak in different countries. So if you graph the number of, if you put all these countries on a single graph, you clearly see 2 groups of countries: the Asian countries and essentially the rest of the world. So why did the outbreak behave differently in Asia and in Europe? Well, there may be many different reasons, but 2 reasons that I'd like to focus on is the type of response and the timing of the response. And really, any outbreak response in the absence of a vaccine is going to rely on 3 key pillars, and these pillars are no different for COVID than they would be for outbreaks of any other diseases. And some of us may have been involved in Ebola, in Zika, in other diseases. The approach has a lot of similarities. The first pillar is case finding, identifying infected individuals as early as possible and isolating them. The second pillar is contact tracing, identifying contacts of these infected people and monitor them for the required amount of time until they either become cases themselves, in which case they become managed as cases, or they go long enough without any symptoms to be have enough confidence in the fact that they haven't been infected. That is the second pillar. The third pillar is mobilizing the community to engage them into social distancing in order to limit transmission from person to person. And all these three pillars are equally important and have to be part of an overall control strategy. You cannot replace one with another. And in a sense, the earlier and the more stringently these measures are implemented, the more efficient the response will be. And the slower the increase in incidence and deaths will be. And what we've seen really is a much earlier, much more rapid and more stringent implementation of these measures in Asia than in Europe, in particular with regards to case finding and contact tracing. In Europe, we very quickly, in many countries, very quickly became overwhelmed with the number of cases that were occurring, and it became very difficult to identify all of these through testing and to contact trace. So really, the ideal scenario would be to do all these three things as early and as widely as possible. Of course, in order to do this, and in order to do case finding and contact tracing, you need several elements to be in place as part of your national public health infrastructure. The first thing that you need is a strong surveillance system where every suspected case is promptly notified and acted upon, and enough information collected to understand how transmission is occurring in different parts of society, in schools, in hospitals through healthcare workers, in care homes, workplaces. The more you understand, the more efficient and targeted your public health measures can be. The second part of your infrastructure that needs to be in place is testing. And the Director General of the World Health Organization had this test mantra that I'm sure all of you will have heard. And really testing and the ability to confirm cases is a really key part of the public health response. And I think we're going to hear more about testing a bit later today. Unfortunately, in the UK, this is something that we were not able to do quickly, with testing focusing on those individuals who were hospitalized and individuals suspected cases in the community not being tested. And that is a major limitation to the response. The third important element of a public health infrastructure that would enable control or at least mitigation of the COVID-19 outbreak is sufficient contact tracing capacity. Now, traditionally, this is done using trained workers who would be notified and would follow up on contact, regularly monitor contacts on a day-to-day basis. And I was a few years ago when I was working in West Africa on the Ebola outbreak, there were literally armies of people going to all known contacts to check on them every single day to make sure that they were not developing a fever. Now, in a sense, we shouldn't forget that this is, the workforce is incredibly important, and the ability to do this is incredibly important. But today, this traditional approach of using large quantities of people to contact trace can be complemented by technology. And this technology may be as basic as daily SMSs, daily messages to ask people, have you had symptoms today? Have you developed a fever? Have you developed a cough? These are relatively cheap, and there's been examples of collaboration with mobile phone companies in order to do this. And there's also more advanced technological innovation, like, for example, in many countries using proximity sensing functions of smartphones to detect when individuals, when they have their smartphones and they come to a certain distance with someone else who is known or suspected to be a case, they can then be flagged as contacts. These approaches are still experimental in many ways, but they have been used in several countries. Again, it is important to remember that the technology doesn't replace the public health workforce. It is an additional tool that can help and support the public health workforce. So these are worth considering as early as possible, and an honest assessment of what this capacity is in country will help quickly understand what is going to be feasible and what needs to be in place. So if it is possible, using these approaches, if it is possible to keep incidence and transmission down, why has the majority of the world had to lock down? And we now have more than 3 billion people under lockdown. Well, one of the key issues is timing and the speed of response. In many instances, countries have simply waited too long. This is the case in the UK, it is the case in the US, it is the case in many countries. And if we wait too long without strong case finding and contact tracing, then the number of cases can quickly overwhelm public health systems, even in high-income countries with very strong public health infrastructure. And then the only option that avoids a high number of deaths and an overwhelmed healthcare system is a complete lockdown until such a time where the incidence goes back to a level where case finding and contact tracing can be conducted again within the capacity of the system. And because there may be a delay between putting these measures in place and seeing the impact, because it takes time for people to be infected and to die, the failure to implement social distancing, it may give you 2 to 3 weeks of false reassurance because not much is happening, but by the time you see that the numbers going up, essentially it is too late. And if we look at data from virtually every country, that suggests that the rise of incidence is very rapid, and the window of opportunity to implement social distancing in those crucial first couple of weeks is missed, then you're in the situation that we're seeing in Europe, than the situation that we're seeing in the United States. It's also important to recognize context, and there may be settings where social distancing is more difficult than others. And I'm not very familiar with Brazil, but I can imagine that social distancing in London is going to be very different from social distancing in a favela in Rio or in Sao Paulo. So in this context, it is also worth considering additional measures. And for example, masks have been a very topical issue in the last few weeks. And I'm not an expert in masks, so please don't ask me too many questions about them. But although the WHO doesn't recommend using masks for all healthy individuals in the community, there are contexts where it may be justified for some individuals, such as sick people, those caring for vulnerable people, to wear them. But I would encourage you to look at the WHO guidance on masks, which is actually quite permissive and quite flexible and does enable some adaptation to local contexts. If we look at the data from different countries who've been severely affected, such as Italy, Spain, the UK, what we see is that within a few weeks of strict enforcement of these measures, the incidence of disease begins to decrease. And we've seen this in China, we've seen this in Italy, we've seen this in Spain, and we're beginning, well, although it is still very early, it looks like we may beginning to be seeing this in the UK as well. So that suggests that, social distancing does work and does have an impact, but it needs to be enforced and sustained for this period of time. And it can, if it is done with sufficient stringency and sufficient length, it can lead to lifting those measures, such as what we've seen in Wuhan, which has actually lifted its quarantine after 76 days. Nevertheless, lifting these measures will not mean a return to normal and a complete return to normal life, which would include, for example, international travel. And this is unlikely to happen in the time frame of a few months. It will take longer, but nevertheless, at least on a local level, if these measures are implemented early and they're followed, you can expect some return to some level of normality after a few months. However, a failure to implement these measures or lifting these measures too early will only delay return to normal. So I just want to finish with a couple of additional challenges that have arisen as we're understanding more and more about the virus that make the picture a little bit more complicated. The first issue is the proportion of asymptomatic cases, which is still unclear. It's not clear what proportion of cases have no symptoms, and it's also not clear how likely it is that these individuals infect others and to what extent they contribute to the spread of disease. Another issue that has arisen recently and is becoming clearer is that even among those who are symptomatic, it seems that they can infect people 1 to 2 days before they show any symptoms and are therefore identifiable by surveillance systems. And I think these 2 points reinforce the fact that even in a situation with good case finding and good contact tracing on all cases, early implementation of social distancing is an unavoidable pillar of the response to the COVID-19 pandemic. And how strictly it needs to be enforced and how long it needs to be in place for depends to a large extent on the speed at which it is implemented and how well these measures are adhered to and the robustness of the public health system. So I think I'm just on time and I will leave it there, and I'll be happy to take question after the next presentation. Thank you very much.
Thank you very much. Very important that you make some important points to be addressed everywhere. And I want now Mauricio Barreto to start his presentation. Thank you, Mauricio.
Thank you, Rubens, for this invitation. I'd like to, before starting, to put 2 points. First, I was invited yesterday evening to participate in this meeting. Then I'm going to present some slides, but I don't have time to translate every slide for English. Né? And then some will be in Portuguese, but I think the image will be sufficient to express in my talk, to express what's going on. And the second, I'm not, English is not my original language, then I'm sorry about that. I try to do my best to be as clear as possible. Well, COVID, are you sharing? Is okay?
Not well. You have to change the format of the image presentation.
Okay, no, I'm going to form, okay?
Perfect.
Okay, I have a few slides. Yeah, first of all, I'm like to say I'm an epidemiologist and have been working with different things. And given the COVID problem, you start to organize a large network of researchers, yeah. And now you have this network that we call COVID, yeah, that I'm going to present at the end some points. And that you share experience with near 150 different researchers, yeah. A lot of them based here in Bahia, where I live, but others in different parts of Brazil and different parts of the world, including UK. And then I try to put some figures on Brazil, yeah, to contribute to this debate, yeah, and some information that we have so far. Brazil, the first case started in February, in 25 of February. Yeah, and now you start, you have different level of developments. Yeah, this is a picture on Brazil. Yeah, the number of cases on Brazil. You see the last day, you have over 3,000 new cases. Yeah, in one day, in one single day. Then the cases is growing fast. Yeah, with some variation that is not clear why, but it's growing fast. Yeah. And this is another picture, yeah, that is a model, yeah, that put the numbers and project the number for the next 10 days. Now you see, you started the beginning of this exponential curve, yeah, that is very worrying, yeah, and a lot of people, governors and the ministries and the head of health departments are very much worried about it. What this mean in terms of in the next few weeks. Here more some data, yeah, from different states of Brazil, yeah. The Brazil have 27 states, yeah, and they are in different speed, yeah. But one thing is clear: COVID now is all over Brazil, and there is no more any major capital of these states that are the big cities that are not in some stage of development. Now, that is very worrying, yeah, because probably you have a kind of at the same time, yeah, epidemics in different parts of the country. Now, this is very much worrying, yeah, and I think it's an important point to put. Here is Brazil compared with other countries, yeah, because the evolution in Brazil is not so much different than what is going on, yeah, in some countries in Europe and the United States. There was an advantage in Brazil that need to be considered. Despite the federal government have been very reluctant, not the Minister of Health, but the president of Brazil, very reluctant, yeah, to give support to the measure of social isolation. But in general, in the state, in several states of Brazil, the governors, yeah, take this, yeah, as a political decision, yeah, and very, very early, yeah, in some states, it started this measure, yeah. I think this is a very important point, yeah, and you see, you have data from the mobility data, yeah, this is data from the Google, yeah, systems, yeah, they can measure mobility around Brazil. And you see that there was really a very important decrease in mobility, yeah, in Brazil. It's true that this is different on different activities, yeah, but in some way, yeah, the social distance measure in general, yeah, have some effectiveness in terms of the mobility of the population. This, I think, is an important point, yeah. You have been analyzing my group, yeah, the situation here in Bahia, specifically. Yeah, Bahia is a large state of Brazil, in northeast Brazil. Yeah, and you see in this graph, I don't have time to explain, yeah, but this graph is a mathematical models, yeah, using different approaches, yeah, different kind of mathematical modeling approach. But in summary, they show that the measures, yeah, have been deflected a curve a bit, yeah. We're estimating around 27%, but you're not so clear what it completely mean, yeah. But there was some deflection of the curve, and the measures, yeah, to stop and to block the traffic between cities, yeah, that also is taken in the state of Bahia by the governor. Yeah, they stop the traffic in different important points of the flow. For example, prohibiting bars and the others, public transportation and things. Yeah, you see also in this curve that probably you start to have an effect of the curve deflection. Don't mean that the epidemic will not occur at all, yeah, but probably the epidemics, yeah, will be smaller, yeah, because the one of the purpose of the objective of the mitigation measure, yeah, is to decrease the curve, the peak, yeah. And then I think in some way, our evidence that we have been work, yeah, at least in Bahia. There is another analysis in other parts of Brazil that go in the same direction, yeah, in places where there was important measures, yeah, there was some, the curve start to be, yeah, more flat than it will be without this measure, yeah. Michael talked about masks, yeah, about masks. You defend that, Marco. You are, for example, this is a document, that my group produced, defend the use of mask of tissue, locally done, to spread over the population, to be used in any public activity or any outside the household, people use the masks, we think there is not sufficient classical evidence, but the evidence that exists is sufficient to justify this measure, given the practicity, it's very easy to be implemented and could be an addition, to the measure. It is understood, and you also have an effect. These masks are produced, by local people, that can receive some salary, and have an economic activity in these hard times, in economical, given the economic situation. But one problem that is very worrying, is our capacity to react to this big wave, the big that's coming. And you see the data in Brazil are very worrying, because in the past few years, you have been decreasing our capacity, our hospital capacity in Brazil have been decreasing, given the measures, of the from 2014 in Brazil, there was a lot of austerity measures, and the governors, the federal government start to cut, the finance of the national health system, and this is measured, have this kind of effect, decreasing the overall offer of hospital capacity, Here you see some data on beds, per thousand population. You see that there was a decrease also. Now you go in direction of decreasing. Between 2009 and 2017, there is a direction of decreasing. I'm sure here, some data on bed per inhabitants. This is in the southeast region is go to 2.5, but in northeast 1.3, in the north Brazil 1.2. They are less. They have less capacity, in terms of hospital beds, The same thing happened with doctors trained in intensive medicine, capable to run, in intensive units, intensive care unit, ICU. You see the numbers. Only 18% of them are in the Northeast, 3% are North Brazil, 5-7% is in Southeast Brazil. Then there is a very uneven distribution of this capacity over the country. Then this is a point that here are the beds of UCI, intensive ICU, intensive care units, over Brazil. You see there is places where there is some concentration of them, in capitals, big cities, but there is huge areas, without any capacity, in terms of ICU, that sure, when if COVID reach these areas, will be a lot more problem in terms of care, given the geographical distance. Brazil is a map here, but Brazil is very large, long distance, to take patients or to move patients around, in search of the right place, Here are the distribution of respirators and ventilators, Also, you see that there is a very uneven distribution, Sure that this data have been changed quickly, because given COVID, the local state departments are doing a lot of efforts to improve the capacity, but the previous weakness, is a problem, and even if you increase your capacity, that it has happened in the past few weeks, you see a lot of movements, in especially at the state and municipal level in Brazil, to increase the capacity, but the deficiency that you accumulate will reflect certainly, in the capacity that you have at the moment that the epidemic is reached the peak. Here is more some data. I'm going, a synthesis, of your capacity before the epidemics, of care of very severe people. Yeah, you see very much concentrated in Southeast Brazil, and a lot more rare in the Northeast and North Brazil. Well, you have another problem. I think Michael talked about that, that you have, this is an infectious disease, yeah, respiratory transmitted, and you have people living in favelas. You have a lot of disadvantaged groups in Brazil that probably will suffer more than the normal situation, than, for example, what's happening in Europe, yeah? If things go like Europe, yeah, you can predict that here will be worse, yeah, given that part of a population live in very bad condition, yeah, in that very high dense areas, yeah, in favelas and others, yeah, where there is a very more closer contact of the people, because the distance among households is very small. People live in small houses, sometimes large families, or living in very small space. You have the indigenous population in Brazil that is yet significant. You have been people who care about that, are very worried what can happen in this population. You have over near 1 million indigenous population in Brazil. Some of them, a proportion of them live in small conglomerates, yeah, small things, and in general, yeah, this population, for example, has high level of undernutrition and the other tuberculosis, yeah, and the other things. The Quilombola communities, yeah, there is a large number of Quilombola communities, old black communities, yeah, from heritage from our slavery times, yeah, spread all over Brazil, yeah, and this population is very disadvantaged in general, yeah, and it can suffer a lot. Yeah, people experience without house, homelessness, yeah, and these people is growing in Brazil in the past few years, given the condition and the decreasing of the social policies, yeah, and the social protection programs, yeah, this population is growing, yeah. You don't have numbers, yeah, don't only have number or clear statistic about that, yeah, but no, there is no doubt that's an important population. You have prisoners. Yeah, Brazil have a very large prison population. Brazil have near 800,000, yeah, prisoners. Yeah, some states, yeah, there is some movement to free part of this population. Yeah, people without any major problem, yeah, to be released. Some states have done that. For example, here in the state of Bahia, yeah, there were the government released around 10% of the population so far, yeah, of the prison population to try to decrease the density, yeah. In general, the prisons are in very high, very low condition, yeah, with a very high rate of the HIV, of tuberculosis, NCDs in general, yeah, in a very susceptible population, and they are very risky population. And migrants, yeah, the Brazil don't have a very large, but have important now from Haiti, from Venezuela. These migrants in general don't have rights, yeah, or part of them don't have rights of access, yeah, of the availability in the health system, yeah, and then is a very disadvantaged population, yeah, in this moment of a pandemic, Then is that points that I'd like to present. And at the end to talk, in Brazil, there is a lot of efforts from the academic community to be together and to increase the capacity and to offer to the society interpretation, yeah, and the understanding of the epidemics. Here, the COVID, you organize a large group of people, was growing very fast. Now it's over 150 academic people, yeah, researchers, professors, postdocs, docs, students, and different kind of people, yeah. But with a major purpose, yeah, to do good science, to inform the population and in a solidary way, yeah. You forget about the published papers and to put our knowledge to the interest of the society. And one of the tasks of this as Michael called the attention, is to review the literature and review everything that's coming, yeah? It's a very quick pandemic, yeah? It's going very fast, yeah? But you have some gap, yeah? You have a lot of learning from China, from Europe nowadays, yeah? Then what this group one of the tasks of this group is try to digest, yeah, the literature, everything that is going around it, to try to learn, yeah, what come, yeah, and what being produced, yeah, of experience out before Brazil, not to try to apply to our situation. I think this is an important lesson, yeah. You need to learn very quickly, yeah. There is no time to formal learning. You need to learn. We are calling evidence review in real time. There's no more time for systematic review in classical way, but it's a real-time process of join knowledge and try to share that as quick as possible, yeah, to benefit, yeah, of this lag of time, yeah, that the epidemic giving us, yeah, a few weeks, yeah, behind, yeah, other countries, and try to learn very quickly from this experience. This, you have a website, you have a panel, yeah, with information epidemic, and is all. Sorry if my delay, and thank you very much for the opportunity to be talking for this community.
No delay at all. Brazilians know about that, but maybe some of our guests from other countries do not know that in Brazil, people from Bahia is always recognized for not being able to think well, but to speak even better. Mauricio, thank you very much for having you here again. Mauricio was among us during the Zika outbreak and other bad situations. We hope to have you, Mauricio, among us for better results and better environment. Thank you so much. I now like, again, Professor Annie Johnson to introduce the next speaker.
So I think just before we do that, Professor Belfort, we have time for a little bit of discussion for about 5 or 10 minutes. So if there are questions that people have, perhaps the easiest thing is to raise your hand or to say use the chat facility at the bottom of the screen if you look, and just type your name that you will speak. Otherwise you can physically raise your hand and we can unmute you so you can ask a question. And there are so many people, it's difficult to see if there are any hands raised. But if there are questions that people would like to ask or discussion points, please do so now. I'm looking carefully to see if there are any.
Professor Miguel Orion is asking a question. Can I unmute him?
And
Yes,
also academician Octavio Vaz.
Yes.
So Roberto, why don't you allow the microphone?
Yes.
Yes, I have allowed Professor Orion right now, and I'm going to allow Professor Octavio Vaz following.
Thank
Professor
you, Roberto.
Ryan, I understand Professor Ryan is from Chile.
Yes. Do you hear me?
Bienvenido, es un gran placer tenerlos entre nosotros, no solamente a usted, pero también los académicos de todos otros países de América Latina. Muchas gracias, Professor Ryan. Go ahead.
Muchas gracias. Thank you very much. And I'll just ask 2 quick questions. Well, in Chile, like in most Latin America, we're adopting different strategies. Here we have used testing, and we're doing relatively well compared for some standards, not that well compared probably to European standards. And we're using intermittent quarantines, a strategy of putting on and off quarantines based on the increase of cases that's being monitored by the health ministry. So far, so good. We're in, like most of Latin America, in the 2nd month of the pandemic, I would say, first case in March. And I guess my 2 questions to you are, it's rather surprising for me, although that we have to be very careful with case tracing, which is much lower than in Europe. But if we look at mortality rates, which are maybe numbers that are a little bit more robust in most countries, it seems that even though we're in the 2nd month, the overall mortality rates are a 10-fold lower than what is being, and even more than what has been seen in Europe in most Latin American countries today. That can change, of course, in the next month, but there seems to be a difference there. And the question, my first question is, what are your thoughts on that? the worst scenarios that we've been seeing is in Guayaquil, for example, of course. And even if you look at the overall mortality rates in Ecuador, they're still very much fall lower than what was observed in Europe. So that's my first question. What's your thoughts about that? And the second one relates to the issue that this virus attacks us in the summer, late summer, and now we are going into the winter in the next 2 or 3 months. And what, you know, our rates seem to be lower also than what was observed in Europe, with a caveat of testing, of course, but they seem to be lower anyways. And you wonder if that has to do with the fact that actually we were impacted in the hotter summer months, and that we should be expecting a significant rise going into June, July, which is our winter, which means that we will have to be even more strict in the quarantines and tracing for more months, maybe not just the 2 months, but up to 4 or 5 months to be able to put this under relative control. So those would be my 2 basic questions. It would be very helpful to hear your insights.
Okay. Muchas gracias. And Michael, would you like to respond to those questions?
Yeah, sure. Podría contestar en español, pero voy a contestar en inglés. So the first question about mortality is an interesting one. There's several. I mean, even within Europe, there's quite a few differences between countries in terms of mortality, and some are essentially data artifacts. And you mentioned testing, and testing is the first variable that will really modify case fatality rate. And in a sense, the case fatality rate, the proportion of cases that die, is a direct consequence of who you're testing. In the UK, for example, where you're only going to test people who are in hospital, you're going to bias your testing towards the severe end of the spectrum, and as a result of that, the proportion of cases dying is going to be higher than in a country that tests, you know, in the wider community, such as Israel, for example, which has, you know, a much lower case fatality rate. That is the first potential factor. I don't know what the testing policy is in Chile, but that would be the first thing to compare. It's quite difficult, and those nuances make international comparisons very difficult. The second factor is that we know from fairly large case series and sort of early studies, the early papers from this outbreak about risk factors for mortality. One is age, and we've seen in Europe that countries with an older population, such as Italy, tend to have higher mortality than countries with younger populations. And there are also other risk factors like obesity, for example. Obesity is a major risk factor for developing ARDS, respiratory distress, and in countries like the US, where 30 to 40% of the population is obese, that is undoubtedly an important contributor. And the third one, which is I think less well understood, and is slightly outside of my area of expertise, but is, you know, everywhere in the world we see clear risk factors and epidemiological associations between age, obesity, etc., and mortality, but there are also counterfactuals of individuals, and in some instances populations, who are young and with few risk factors who do see a fairly high mortality. And there is some evidence that some genetic polymorphisms predispose to more severe outcomes, although that is very early research. So I think the differences, without knowing too much about Chile specifically, the differences could be a combination of a different underlying population structure in terms of age and in terms of risk factors, partly artifact because of different testing policies, and partly different genetic makeup of the population.
Michael, thank you. I'm going to turn to Professor Barreto. Did you want to answer the question about seasonality?
Yeah, I like to put a question to reflection, because I think the first big epidemic is where testing was central, because testing is part of any study of any disease. But in this case, people put test. I'd like to challenge a bit this idea, without any, because I think there is a lot of confusion, because one thing is, if you increase your base of diagnosis, and you get more no severe cases, your fatality rate decreases. This is immediately, is automatically, it's a question of a numerator-denominator system, Another thing is that where more tests was done, they also have a better health system, capable to care more about the population. Then example of Hong Kong, Singapore, Korea, a country that have a huge infrastructure of health capable to care. Then I don't see anything strong in the literature. Maybe I missed that. That can agree, that tests are central, to decrease case fatality rate or other things. I understand that case is very important for surveillance. It will be very important in the new stage of pandemic. Our capacity to detect case, detect focus. Then this depends on an infrastructure of public health that you need to care about that. Brazil have a huge network of primary health care. It's one of the best structure in the developing world. I think this infrastructure, if you put it some technology like tests, could be very, very much effective. But the general idea that testing is the cause of decreasing fatality rate, I dispute this idea. I have seen any convincing arguments, that put this on a clear demonstration that this is true.
I think again you're raising the issue about it's an artifact of who you test, and you're identifying more people with mild infection. I think we should. I'm very conscious I'm already running over time, and I know there was one other person wanting to speak. We haven't dealt with the issue of seasonality, but just to say quickly, there is evidence of emerging clearly that other coronaviruses do transmit less in the summer than the winter, and we will have to see how this changes in Europe as the seasons change. But I think there is a risk there. Roberta, you had one other speaker. Could we make this a very...
Yes, and we are 3 minutes behind, but academician Octavio Vaz wants to ask a question. I know it's usually very quick, so...
But if we have one very quick, I didn't want the academician Octavio to be left out, so let's deal with that question very quickly. Could we ask our speakers also to respond quickly? Thank you very much.
Octavio Vaz. Roberto, Otávio Vaz. Microphone, Otávio Vaz, por favor.
Are you hearing?
Yes.
I want to first congratulate the speakers for the excellence of their presentations. And Dr. Mauricio called attention for something that is happening all over the world. The shortage of ICE intensive care unit beds. We know that the population is getting old, and most of the patients that goes to the hospitals to be operated on, they are old. They are considered old people. And on the post-operative, they go to special units like post-operative, cardio-intensive, intensive care unit. My question is, do you believe that this pandemic will change the hospitals? I mean, we need to have more ICUs, beds, or special units for the next pandemics, because this is not going to be the first and the last. We have to be prepared for the next ones. What is your opinion about that?
Anne?
About intensive care beds, yes. Michael, do you want to take the issue of intensive care beds? Roberta, you'll have to unmute. You have to unmute Michael.
Yeah, I mean, it's slightly outside of my area of expertise, sort of planning capacity, but it's always a challenge to sort of, you know, plan for rare and dramatic events. I think, you know, you have to strike a balance between how you know what capacity you need it's sort of in terms of business as usual, and more capacity you need for surge events like this. And this is really the job of preparedness. I think it's been quite remarkable in different settings how quickly in China they've built a massive hospital in the space of a few days. And to blow our own trumpet a little bit, in the UK as well, they've, you know, in the space of about 10 days, they've built a hospital in a convention center with 2,000 beds, and in 2 additional ones with 500 beds each, which can be expanded if needed. So I think you're right. I mean, I think it's not an easy calculations to make. I'm not an expert on how to make these calculations, but clearly there is also the possibility of very rapidly augment this capacity in exceptional circumstances like the ones we're experiencing now.
Thank you, Michael. Let's leave it there. I just would like to say we can pick this up because we have we'll be having a presentation later from Professor Singer, who is running the intensive care unit at UCL, and will tell us more about ramping up capacity, but also possibilities of other ways of managing acute respiratory distress through other technologies such as CPAP, which he'll tell you about. So I think perhaps I know there are a lot of other questions to answer, but I think we will have to move on now. If I can thank our 2 speakers for excellent presentations. And now if I could introduce Professor Susan Michie, who is Professor at University College London, and she has been working and advising our government on social and behavioural aspects of the epidemic. And she runs a large group of researchers. She's a health psychologist by training, and she's director of the Centre for Behaviour Change. And she's going to talk about some of the social and behavioural aspects of the epidemic. Susan, over to you. Will you share your screen?
Thank you. Good. I hope you can see the screen. As Anne said, I'm director of a Centre for Behaviour Change. We're a cross-disciplinary group who specialise in translating academic expertise to policymakers, practitioners, whoever wants to use it in various ways. As was said, I'm on the UK's COVID-19 Scientific Advisory Committee on Behaviour. This is part of, yeah.
Sorry, we can't see your screen.
Oh, sorry about that. Okay, so share.
There we are. Yes, good.
Oh, great.
Got it.
Okay.
Put yourself on full, you know, slideshow. Yeah, great, perfect. Thank you. Go ahead. Okay, to just say something about how the scientific advice is given to government, there's a committee called SAGE, the Scientific Advisory Group in Emergency, and it has input from 3 subgroups plus a network of experts. There's a modelling advisory group, a clinical and virology advisory group, and a behavioural advisory group. Sorry. My roles are being a member of the Behavioural Advisory Group, and I'm also acting as a consultant to WHO applied in behavioural science to COVID-19. The Behavioural Advisory Group includes psychologists, anthropologists, sociologists, amongst others, and we draw on a range of sources, so published literature, unpublished reports, survey and focus group data, and expert opinion. And we produce papers to advise government on a range of issues, but they include issues like school closures, self-isolation and household isolation, options for lifting or tightening restrictions, possibilities of social disorder and policing strategies, improving adherence to government guidance, how best to present diagnostic and antibody testing,
effective communication strategies, and managing deaths and funerals. So that gives a sense of the range of different topics that we address. One of the things I'm going to present here is a behavioural perspective on transmission routes in order to identify behaviours to block these. And this is helpful in developing and evaluating interventions to achieve population level changes in behaviour, taking into account the material and social context of the population, which obviously varies enormously between and even within countries. So the limited health services in some countries, overcrowded housing, insecure informal employment, limited access to resources such as soap and water. All of these things impact on what kind of behavioural strategies are likely to be most effective. So here is a rather complicated diagram of the pathways to transmission. But if you look at the circles, first of all, starting on the left-hand side, starting with the infected person expelling droplets, you can see that there's either an aerosol, there's a surface and objects, or there's one's own hand, next point at which the virus can move forward. Everything to the left of this blue rectangular is to do with the person, and then moving to the right of it, others inhale the droplets, others touch contaminated surfaces and objects or the other person's hand. And one can look through the whole way in which this transmission happens. Now, in the squares, you'll see the various kinds of behaviours that can interrupt these transmissions. Catching the sneezes and coughs in a tissue, discarding it appropriately, washing the hands with soap or a sanitizer, disinfecting surfaces and objects, keeping a distance of 2 meters, and using face masks, I say as appropriate. In view of the previous discussion, I will make a comment on this. The evidence is really quite equivocal about the use of this in communities, and human behaviour is absolutely key to understand this, because it's not just a question of the viral transmission through various kinds of materials, it's how humans in their everyday lives actually interact with face masks. First of all, they may use inappropriate ones with all sorts of cloth or rather inadequate materials. Very often you'll see people fiddling with their face masks, putting them on and off, touching them. This can contaminate hands, which then contaminate surfaces. Often the face masks don't fit properly, so people think that they're protected or protecting others, but actually they're not. There's also a problem of false reassurance. People may change their behaviour because they're wearing a face mask, forgetting that their eyes are ways in which they can touch their eyes, or they don't socially distance so much. So this is an example where it's not just a question of looking at the technology, but it's how people actually use the technology in their everyday lives. So here's a list of the personal protective behaviours. None of these really cost anything. And if the population were to adopt these, we would not have a problem. This would just break the transmission from person to person. But the challenge here is, how do you get populations to adopt these behaviours day in, day out and at scale? And just to give an example of the fact that one needs to understand each behaviour in its context to know how best to develop strategies to change those behaviours. So if we take washing hands with soap, this requires establishing new rules. Things like we know are effective, what are called if-then plans, which links behaviour with particular settings. If I come into buildings, if I'm about to eat or prepare food, then I wash my hands. So one really needs to get these established as cultural expectations throughout society. Now, not touching what's called the T-zone, the eyes, nose and mouth, where the virus gets into the body. This requires an automatic habit. Very few studies have been done on this, but we know that something like 20, 25 times an hour, people are touching their face. usually without being aware of it. So that's not enough just to make a rule because one's not aware that one's doing it. One needs to develop an incompatible behaviour. For example, keeping one's hands below shoulder level. A different kind of behaviour, a different kind of solution. Sneezing and coughing requires accessible tissues. So new routines to ensure one actually has tissues to hand, for example, checking one's bag or pocket every morning. Social distancing is more complex because it depends on other people, one's neighbourhoods, both social and environmental, work situations, travel options, etc. So for each behaviour, one needs to understand the context before suggesting interventions. And I want just to give a story that happened a couple of weeks ago in the UK that really illustrates how not to do things and how things can be done without understanding the behaviour. So in April, our health secretary, when they saw that one sunny weekend, lots of people seemed to be congregating in parks, said that if this went on, there'd be a lockdown and people wouldn't be able to go outside. However, the polling data we have shows that despite there being lots of pictures in the media about people being crowded in parks, this actually represents 2% of people and 99% of the population want to adhere. So the problem wasn't motivational. The problem was opportunity because people were going to the same parks at the same time. So this is the reason that they weren't being able to keep 2 meters apart. So if one decides or knows, because one looks at the evidence, that the problem is about opportunity, not motivation, then what we need to do is actually open up the parks even more. In London, for example, we have 45,000 acres of golf courses that could be opened up for people to walk on. We have lots of school playing fields that are closed. So the point I want to make here is understand the nature of the problem by looking at data and evidence before jumping to conclusions and coming up with solutions that aren't appropriate. Now, I want to share with you the simplest possible model of behaviour that at the same time is quite comprehensive. And COMBI stands for capability, opportunity, motivation, and the B for behaviour. And this is stating that for any behaviour to occur, one needs the capability. So, for example, let's take the 2 meter distance. First of all, we need to have the knowledge that that is what is being required of us. Then we need the motivation. We need to care about doing that because we know that if we don't do that, the consequences will be very severe to ourselves, our loved ones, our communities. But even if we have the knowledge and even if we care, as I've just been illustrating, one needs the opportunity to enact the behaviour. All those 3 things need to be in place and they all interact. So even if, for example, it may be a motivational issue, one can still deal with it by providing more opportunity, encouraging the behaviour, that then can encourage the motivation. So that's the simplest way of thinking about behaviour. I want to now go on to give examples from some of our thinking on the committee, just taking 2 examples, adherence to social distancing and communication, which is very key to changing population behaviour in this kind of situation. So the kind of principles that we've been talking about in terms of improving adherence to social distancing is appealing to altruism. The evidence suggests that helping others, helping one's health service, the economy, society is a much greater driver than necessarily helping yourself. So appealing to social solidarity and collectivism being a very, very powerful driver. And we're using this in our messaging and our promotional adverts at the moment. Very important to provide explanation with the advice, not just what people should be doing, but why they should be doing. So they have a mental model of why they should be doing what's being asked. So ensuring that we treat people with respect and capable of taking decisions for themselves and managing their personal risk. Another principle that we promote, again, all based on evidence, is facilitating rather than directing, enabling rather than punishing is more effective. So telling people what support is available to help them adhere, providing resources, helping households plan how to socially distance and review these plans regularly. then very importantly, we have massive inequalities in our country as in yours, acknowledging the different situations that people are living and working in, and especially paying attention to those in the most disadvantaged situations. So introducing measures to differentially help those that are struggling most, and understand what the main barriers are to adherence. For example, financial insecurity, low income is a huge one. Boredom, domestic abuse, and celebrating the majority who are adhering rather than the minority who are not. So in our country, even though we've had amazing, I think, beyond the expectations of most of us, adherence to the social distancing, the staying at home messages, there's been quite a lot of focus in the media and by some politicians on the very small number who haven't. Not helpful. Then some of the principles of, yep.
Just a couple more minutes because we're getting a bit short of time, okay?
Okay, I'll go through this very quickly then. Using simple, clear and consistent messaging, being transparent about why the government's taking certain measures, demonstrating empathy around difficulties, I've said that one, measuring communication. Final slide then, being precise, tailoring, motivating and enabling, promoting trust and showing respect, and a few don'ts. Don't give vague advice or suggestions, don't use stereotypical or divisive messages, and don't show or imply that people are doing undesirable things. And I won't go through the rest, but just to finish off with, oh dear, I can't go back here. Just a few, if anybody wants to follow up on this, a few blogs in BMJ and a longer paper coming out in Nature Human Behaviour.
Thank you very much, Susan. Sorry to rush you at the end. I'm sure that there were lots of positive chats coming up there. And thank you. If you're content to share your slides, let us know.
Absolutely.
And I'm sure people will be delighted to have them and they can study them in detail later. We will have time for questions afterwards, but now I'm going to hand over to Professor Belfort to introduce our next speaker.
Yes, that's an excellent talk. Congratulations. But the next speaker is our academician, Paulo Bus. Paulo Bus has been a key person in these epidemics, as well as in the fight for better medical system in Brazil for decades. Paulo Bus is an example of a leader that we need in this situation, and also has helped a lot to organize this meeting. So it's a great honor that I invited now Paulo Bus to address to all of you. And I want also to let you know that we're keeping 150 people attending this talk, or approximately 100 people in this platform, and also a good group on Facebook. So congratulations for the other organizers for this successful meeting. Paulo, go ahead, please.
Okay, Ruben, thank you so much. Good afternoon, everyone. First of all, I greet the Academies of Medicine and Medical Sciences of Brazil and the United Kingdom for this brilliant initiative to hold this meeting on cope with COVID-19. And hi, Ruben. Hi, Anne. Thanks for your leadership. I also appreciate it for the invitation to speak about how epidemics get worse the bad social conditions already existing. And for the same reason, elected by my friend Mauricio Barreto, that is speaking in a language other than mine, I apologize in advance for any misunderstanding. And not to exceed the 15 minutes allowed, I decided just to write and read my speech in this debate without using slides, okay? So let me say also that Mauricio's presentation has already brought rich contributions, not only to the epidemic in Brazil, but also to various aspects of the epidemic's social dimension. So I thank him for facilitate my contribution. And thank you, Susan, for your so clear and rich presentation about the human behavior and social psychology regarding COVID-19. I appreciate a lot. And I would like to have available of your presentation because it's quite useful for us in Latin American and poor countries, because it's very clear the model you have been using and the recommendations that come from the model. Well, I think that there is a consensus among public health researchers and professionals around the world that the COVID-19 pandemic will amplify the deep existing socioeconomic inequities, because they are already vulnerable and marginalized population worldwide are at increasing risk of exposure to coronavirus due to their precarious living conditions. And I mean overcrowding, physical inability to follow social distancing, and frequent hand washing, like we used to say, and because the types of jobs. Also, once infected, they are more likely to die because they suffer high prevalence of other diseases and lack access to healthcare. I mean that whether due to the greater difficulty of maintaining social isolation, employment, and including income, either by less access to health and basic sanitation, there is a consensus that COVID-19 will disproportionately affect the poorest. Therefore, simultaneously looking for technological solutions to the diseases such as medicines, vaccines, diagnostic tests, and medical devices, as well as protection for health professionals, a fundamental action in facing the epidemic is to mitigate the epidemic's impact on the social determinants of health, which are amplified in vulnerable patient populations. There are several dimensions that make low-income populations most exposed to contamination by the new coronavirus, such as the use of public transport, the largest number of residents per household, the lowest access to basic sanitation, less access to health, and the difficulty of maintaining social isolation without loss of income or job. And population studies with data on epidemics of previous respiratory infections, such as the 20th century pandemic flu or H1N1 and SARS, have shown that social inequalities are determinant for the rate of transmission and severity of this disease. In Brazil, the study of COVID-19 epidemics is quite complex due to its large territory encompassing different ecosystems, latitudes, climate, cultures, socioeconomic levels, and immense inequalities. Brazil, with its 210 million inhabitants, is characterized by extreme socioeconomic inequality, which conditions the distribution of diseases in different social classes and in the economic and the social gradient. In spite of the fact that up to this date, most of the cases have been among upper or upper middle class persons in the more affluent parts of the cities, with the spread of local transmission, the epidemic begins to reach vertical and horizontal slums and poor communities in large and medium-sized Brazilian cities, like Mauricio Barreto presented in its terrific presentation. Well, the immediate reaction of state and municipal governments was, as advocated by WHO and the experience of the countries that best dealt with the pandemic, reducing urban mobility and asking people to stay at home. Well, as a result, the majority of self-employed workers, who make up about 50% of the working population in Brazil, have drastically reduced their earnings, and many low-wage jobs have been lost. We can say that this population was invisible to Brazilian society and obviously to governments, at least until now. And now they are becoming more visible. And this is not only quite interesting, but quite important also. And therefore, other than with the arrival of the virus, the epidemic by COVID-19 reached the favelas and poor communities of Brazil due to the economic crisis it provokes, generated by the arrival of the virus to the population parts of the wealthiest cities. I mean, the economic crisis arrived to the favelas before the virus. And this is an important social question, social determinants, economic determinant of the epidemics in our country. And one can expect a differential vulnerability among urban population, not only regarding age groups or health conditions, but social status. Because Brazilian cities are the most dual and unequal in the world. According to IBGE, our Institute of Statistics, 14 million Brazilians are in extreme poverty, earning less than $30 a month. And the poor people earning less than $100 a month are around a quarter of the population, close to 53 million people. These include street vendors, drivers, porters, housemaids, caretakers of sick and elderly, among other kind of jobs. And for them, go out to the streets for work is a need, not an option. And regarding the poor communities, there are around 6,500 communities in Brazil with precarious housing, very densely occupied and with deficient public services. In urban outskirts and favelas, in around 360 municipalities where 12 million Brazilians live. And those are likely to be the most affected by the social and individual consequences of the epidemic. Because these conditions favor and potential the epidemic's emergency and lethality. So in average, 93% of urban populations has piped water services in Brazil. However, from around 5.6 thousand Brazilian municipalities, only 2.6 thousand serve 100% of their population. This large number of households is not served by piped water. Essential, I mean, for the most recommended preventive measure by WHO and by the Ministry of Health, wash hands with water and soap frequently. On the other hand, the positive things. Brazil has one of the largest and most complex health systems of the world, the unified health system we call SUS. And SUS provides integral, free, universal access to the totality of Brazilian population without any discrimination regarding origin or nationality. And its actions are solidary and participative among the three levels of government, federal, state, and municipal, and form a widespread network of preventive actions and healthcare services, encompassing primary care, intermediate care, high complexity care, emergencies, hospital care, epidemiological, sanitary, environmental surveillance, and pharmaceutical assistance. So about 75% of Brazilians rely on this public health system, and 25% on private health insurance. So at this critical COVID-19 epidemic, SUS represents the most important Brazilian asset. This importance is highlighted by the family health teams created in 1994 and formed by medical doctors, nurses, nurse assistants, health agents, usually from the community, that act in all Brazilian municipalities. In February 2020, there were 58,000 health family teams in the SUS, acting in the country, mainly among low-income population and communities. And these teams will have an essential role in preventing the widespread of the pandemic, according to the analysis of many researchers, and including the health ministry. Well, I think this is my central contribution. But I would like to say two other things. First, to deeply regret the Trump administration's position that certainly not in line with the views of the majority of the American people, of suspending the United States contributions to the World Health Organization. This is a disservice to the American nation and also to the people of the earth at such a grave moment in the old history. And finally, I would like to inform you that a group of institutions and individuals, including doctors and other health and public health professionals, as well as scientists and global personalities, and this includes our Academia of Medicine and the Brazilian Academy of Science, are sending a letter to the Secretary General of the United Nations in support of WHO and calling the attention of the United Nations and WHO to the issue of health, social, and economic equity. That is, calling for special attention from the rich UN member states and from United Nations agencies to the need to face the pandemic with the glasses of equity. Because the poorest countries and populations in the world, where the epidemic is now coming after the slaughter developed countries, desperately need economic and health support. Otherwise, something is expected to look like genocide in the African population and in the poor populations of the Latin American and Caribbean nations. And I invite you to know the letter and if possible to sign the letter. We are organizing to send to UN and WHO. Thanks so much. This is my modest contribution. Thank you.
Thank you very much, Paulo. I understand that we have maybe some time for quick questions. Anne, would you like to coordinate this?
Professor Belfort, I think it's your turn to coordinate the discussion.
Okay, okay.
Yeah, thank you.
Okay, is there any question? Anybody that would like to ask a question? Yeah, I have Yuri with the hand here. Could I have the microphone for Yuri? Yuri, could you physically raise your hand? So it's going to be easier.
I have already liberated his audio.
Go ahead, please. Short questions, please.
Yes. So I would like to congratulate both speakers. My question is to Susan. Now we are leaders of, we have some leaders of the world like our President Trump advocating to just stop the lockdown measures earlier, even like earlier than he was supposed to do. That now, at least in the USA, is April 30th. So my question is, based on your knowledge, do you think if they lift the restrictions, people will start doing, go to business as usual and are gonna start to meet again? Or will you have a time where people are gonna be afraid to go to the street and meet other people before we have, after they lift the restrictions?
Thank you for the question. I think it very much depends on the government handling and the government messages of the lifting of restrictions. So just as the strategies have had quite powerful effects on bringing the restrictions into being, so they can have powerful effects in terms of enabling and supporting the population to adjust their behavior so that it keeps the transmission minimized as they begin to go about the activities that they previously were going about. So I think that what we're seeing is that populations can be very adaptable given the right leadership and the right support. And that is true for easing the restrictions just as it is for imposing restrictions.
Thank you very much.
Thank you very much. I do not see any other people asking questions, so I think we should proceed. And I'm very happy and proud that you're being able to keep the time under control. I know that to work with our United Kingdom colleagues, they expected it from us. Thank you very much. So Anne, would you introduce the next one?
Yes, I'm delighted to. We're now going to move to the session on clinical and laboratory aspects of the epidemic. And I'm delighted to welcome Professor Maria Zambon, who is a fellow of our academy and is from Public Health England, where she's an internationally renowned virologist and has been working on a number of aspects of the diagnostic capacity for COVID-19, including both virological assays and also the development of antibody assays for detecting immunity and past infection. Maria, over to you.
Good afternoon, everyone. Can you see the screen? I hope I have shared it.
Not yet.
Cannot.
We can't see it yet. We can't see it yet.
Oh dear. Sorry, I will try again. I hope this isn't going to be problematic. Let's just see what happens.
Yeah, you've done it. Yes, marvellous. There we are. Oh, no, now we've got your emails.
No, you don't want my emails.
That's it. So if you can press the slideshow button.
That's it.
Fantastic.
Okay.
Yeah.
Okay, very good, folks.
Well done.
All right then, so it's going to be a mixture of sort of things that we've done and some general comments about strategy and tactics, mindful of time. So the one thing I want to emphasize and keep in everybody's mind here is that this is not intended in any way to be a kind of suggested blueprint or anything like that for how Brazil might choose to approach things, but mindful of the fact that there are very diverse situations in the United Kingdom compared with Brazil and South America. It is just worth keeping that in mind, and we are very, or I am very cognizant of that in speaking to all of you. And by the way, it is a pleasure to be with you and to try and share some of the experiences that we have had. All right then, so the role today for me is to say something about the kind of way in which we've implemented diagnostics for coronavirus, and there have been some good things and some things that are not so good about what's happened in the United Kingdom. But fundamentally, the important thing to try and convey is the fact that the way in which we've adopted diagnostics for coronavirus has been dependent on the development of what you might call in-house capability in the very first instance, but recognizing that in order to have a distributed capability and capacity, there would have to be an evolution of the way in which tests are actually provided. And that in turn is a measure of what our health system is able to deliver, because our national health system, whereby most clinical microbiology testing is delivered, is heavily dependent on the commercial sector and is not really suited for delivery of what you might call in-house tests for coronaviruses. So coronaviruses are large RNA viruses, and overall we do recognize the endemic respiratory coronaviruses, but don't do a lot of, that is the kind of OC43 and 229E coronaviruses that are associated with seasonal respiratory infection, but we actually don't do very much testing for these at all within our health system. Obviously, with a new virus, you need to start right from scratch, developing new tests that are both specific and sensitive. And we do rely, for that reason, on use of PCR. So over many years, we've been very fortunate in the United Kingdom in that we have had strong collaborations with academic groups in Germany and Hong Kong, working on coronaviruses as a group, which meant that very early we were able to use those international collaborations to help design and develop tests that we thought were suitable for use for detection. And those are the ones that were published very early on the 23rd of January. And though that kind of work internationally to make sure that we actually had reasonable detection strategies that we knew would work were really possible because we had those pre-existing collaborations, but also the fact that within those collaborations we had academic groups who worked on things that were nothing to do with human infections, particularly interested in bat infections. And they actually had some of the right kinds of reagents that were necessary in those very early days. And the reason I make that point is that somebody earlier in this session has said that there is quite an upswell of interest from the academic sector in providing support and societal contribution, which is outside of the publish and the kind of publication imperative, and that's relevant because expansion of testing capacity and capability needs to leverage whatever a country has at its disposal. And therefore, the use of the academic sector in this sense is an extremely important one. So our first approach in the very early days of January, when we heard about the virus in China and what was actually going on in China, or at least the information that came out, was to initially say, well, for sure, we need a national capability delivered centrally, and we may or may not need a distributed capability, depending on what happens. And as time went on, it became clear that there did need to be a distributed capacity, which we have done through our public health laboratory networks. There's a little picture of England with some red dots throughout, which just represents the sort of public health laboratories. So in essence, the general strategy was develop what we thought were good tests and then place them in our regional public health laboratories, at least as an interim measure until the arrival of commercial test platforms, which we were fairly certain would happen very quickly. And indeed, that is something that has happened at great speed, but is also problematic within countries because industry, in trying to get their various different offerings accepted and used, completely bombard and inundate any kind of testing facility. So at national level, there also needs to be some way of looking at what kinds of commercial tests or approaches that might be suitable for the environment in which those tests could be placed. And we did set up a separate grouping to do evaluations of commercial kits to try and work out which ones were fit for purpose and could safely be used within our health system. So this is a graph of starting in January and taking us up to sort of, can't even read it myself, about mid-March. And the reason for showing this graph is really just the increase in capacity growing day by day of the number of tests that we actually had available through this testing system, which was primarily, well, at this time, exclusively oriented towards symptomatic illness. And you can see going from 0 up to, thousands of tests a day is something which takes quite a feat of kind of commitment through this health system. But other point to make here in general is the difficulty in supply chain. So just as we have a huge increase on the demand side, so industry has a huge increase on the supply side, and that has meant that industry, in trying to meet the challenge, has often had problems itself in delivering reagents or kits, and there have definitely been serious issues with supply chain and with quality assurance of reagents, which is a significant problem when you're trying to introduce new tests. So then the next slide here is something that I thought you might find useful because there are some important principles about how you apply diagnostic tests. So what I've got at the bottom is the number of weeks of illness, and what I've got at the side is the kind of CT values that you might have in PCR detection, and across the top is the suggestion of the length of time that illness takes place and when recovery starts to take place. So on the left-hand side, where you can detect virus, that is primarily detection or use of diagnostics for incidence work, whereas the detection of antibody is very much for detection of exposure. So some of the things that we have learnt from our detailed virological analysis is that virus detection and virus shedding is really highest right at the onset of symptoms and declines thereafter as measurable by PCR. We have not really been able to recover infectious virus after about day 7 or day 8 from people who are infected after their symptoms onset. And that is the basis of some of UK policy, where we indicate for people who are self-isolating in the community that we say 7 days is the kind of rule of thumb that we use. We also know that about 1/3 of cases have virus detectable in stool, but we know that this increases in the sort of 2nd week of illness. And we also know in those that have fecal detection of virus that shedding can go on for really quite some time, but that is not equivalent to the recovery of infectious virus. So my point there in spending some time on this is that it is important in thinking about how tests are used and understanding of predictive value of different kinds of tests. So a really key point is knowing when people start to become unwell. So as of yesterday morning, around about 250,000 people have been tested in England, and testing is a very hot topic for us, as I think previous speakers have alluded to, in part because we do not have not had in the United Kingdom the distributed testing capability that is possible in a number of other countries, and that is really related to our sort of health system and the kind of system constraints that are present. So just trying to say a few more words about the testing tactics, then I've indicated that for infection, which is about virus detection, but is also important for incidence, understanding the incidence of infection in the community, the kinds of tests that you do are very dependent on detection of virus, and the most sensitive tests are the PCR tests I've talked about, but they are actually very dependent on having lab infrastructure. And as industry develop their offerings, I think we will see rather more point of care tests which are dependent or which use PCR technology. And these are things which are much smaller devices and can be used much more widely in quite diverse settings. We have not looked yet at point of care tests which detect viral antigen, that is viral protein, but we do not anticipate that they will be satisfactory from the point of view of sensitivity, although specificity may be good. And that is in part because of the sensitivity limitations of the actual technology per se. If instead we're wishing to look at exposure with a host response, then the kinds of approaches are similar in tactics. That is, techniques which involve laboratory work and are therefore always going to be constrained, as opposed to things which might be more population useful, such as dipstick type personal devices, for which our kind of, although we haven't done any work ourselves, that has actually been looked at in university collaboration within the United Kingdom. We don't yet know the results of that, but we suspect that these will also have significant limitations by way of both sensitivity and specificity. And I'll say a few more words about that later on. And also necessity to understand the relationship between antibody, which signals detection or exposure to virus, and antibody which signals immunity, which we do not have a good understanding of. So if you think about individuals in the community, you've got a number of different categories. You've got those that are infected, and they could be either asymptomatic or symptomatic, but understanding those will tell you about incidence of disease. Those that are exposed but asymptomatic, this is the contact tracing idea. Those that are recovered and those that remain susceptible. Is quite difficult to distinguish those based on clinical syndrome, but knowledge about how much you have or how many you have of those does require some understanding of what you know about immunity and what antibodies will tell you about detection versus immunity. So the types of testing then are stratified in this way: incidence versus exposure, and there are different kinds of approaches and different sorts of things that need to be done generally, different populations as well. And we certainly have concentrated most of our testing in hospitals, and there has been quite a bit of difficulty about the fact that capacity has been constrained within the system in dealing with healthcare workers and care workers who become unwell. And we are only at the very beginning of our exposure assessments through antibody testing.
Maria?
Yes, coming to the end.
We're running a bit short time, so.
Yeah, okay, so maybe I should say that we have undertaken massive capacity expansion, which is well underway now, and that will change the way in which we use tests and what kinds of testing we can do within the population. Sort of mindful of time, want to mention that there are huge challenges to scaling up PCR testing, and they will not be unique to the UK, although the UK's problems may not be those that exist in Brazil. And there are plenty of innovations about how things can be scaled up. To just finish off, I wanted to say a few words, sorry to flick through these, about who to test, and the fact that it is important to try and pick out people who are mildly unwell, because those may actually be very important in seeding infection in the community, and that might be the younger people who are pretty asymptomatic. And thinking about how to do that, I think, is quite problematic. So last couple of slides was just to mention the fact that, and this might be something that is very worth people understanding, is that there are many different targets. Coronaviruses are big viruses. There are many different targets for proteins which will allow the development of an immune response. And some of those proteins may tell you about exposure or rather antibodies to those proteins, may tell you about exposure, but not tell you about immunity. And that is very important because an early antibody response may not be indicative of immunity. And I think that's a very key point. Here is an example of some serological work that we've undertaken. What we can see in UK patients is that we start to see an antibody response around about day 10 post infection, but the triangle right at the end is our very first UK case who did not develop a fully mature response until around about day 30 or more. And so the general point here is that mature immunity takes time to develop, and what you have early is not necessarily indicative of immunity. I think I better stop there, but just wanted to say that within the serology world, it is an evolving field, and there is a lot to learn generally about the different types of immune responses that we might be looking at. That, I think, is my view of what social distancing might look like in Rio, but let's see if there are any questions. Over to you, Anne.
Thank you very much, Maria. That was really helpful. And I think, you know, this question of antibody testing, hugely important, but we're really at the beginnings of having adequately sensitive and specific tests. So thank you for that. Maria, would you be prepared to share your slides with the group? I'm sorry to hurry you, but there was a lot of interesting material I was really wanted to look at in more detail. Will you be happy to share that with the group?
Yes, I'll send some of them around. There are one or two that are a bit sensitive, but
yeah, those that you feel able to share, I'm sure people would appreciate, because there was a lot of really excellent material. So thank you. I'm going to pass now to Professor Mervyn Singer, who has really been actually on the wards, I think, today. And I'm terribly grateful to you for talking to us, Mervyn, late at night, because it's now, the sun's going down here now, and he's missing his dinner to be with us. So very much, Mervyn. Mervyn is a Professor of Intensive Care Medicine at University College London, and is busy running the intensive care unit in one of the busiest centres in the UK, looking after patients with severe disease. So over to you. Thank you, Mervyn.
Lovely. Thank you, Anne. Can you hear me, everyone?
We see you well, and we hear you well. Thank you very much.
Perfect. Lovely. No, thank you very much indeed for the invitation. I'm, as Anne said, an intensive care doctor in London, and obviously it's a great pleasure to be joining everyone in Brazil tonight. And I love coming to Brazil. This is me last year in Natal with some lovely Brazilian intensive care colleagues. So hopefully I'll renew acquaintance with your lovely country in the not too distant future. Sorry, I've got some drawing on thing, it doesn't matter. So essentially, this is a weird disease. It's something we haven't seen the like of before in intensive care. We still don't understand the pathophysiology, the role of the virus, the role of the person's adaptive immunity. We don't have any decent evidence base upon which to judge best treatment. There's no proven therapeutic, and there's no proven adjunctive therapy that can definitively make a difference. We have a problem. It is a horrible disease. It's very unusual, and if you get it badly, it's very nasty. And I don't know if you hear, there's cheering outside. At 8 o'clock, people come out and clap the National Health Service. So I don't know if it's distracting from my voice, so apologies. I'll shut the window. It's going to carry on for a minute or two. Sorry, apologies. That's a way of the public showing support for the health service. So we have in these patients an initial presentation with hypoxemia. These patients often present with profound desaturation, saturations in the 60s, 70%. And though it's often silent, they often look remarkably well, and some patients tolerate hypoxia remarkably well. But as you see from this series of x-rays, it can progress very rapidly and patients may become very uncomfortable or distressed by their breathing. And generally, when the patients present, they usually have single organ failure, lung failure. Few present with an encephalitic presentation, but generally the circulation, the kidneys, the liver, the lactate levels in the blood are all normal. Radiologically, there's this characteristic CT progression going from focal unilateral disease to diffuse bilateral ground glass opacities, and then later on to a more classical ARDS type picture with consolidation. And the lung changes initially from a very compliant lung to a very stiff lung. So high carbon dioxide levels generally are a problem later on. And there are some very characteristic blood tests. So we see lymphopenia, raised D-dimers, ferritin, raised lactate dehydrogenase, and these things with troponin, BMP are often prognostic, and often they can separate survivors and non-survivors very accurately. The other thing I'd like to stress is this very high incidence of thromboembolic disease, both arterial and venous. This is a paper that's just come out from the Netherlands, and over 30% of patients had clinically significant thrombotic problems. And we're seeing that in the UK too. What's the pathophysiology? Unfortunately, we don't know. And I think that's one of the ongoing challenges. There's some features similar to hemophagocytic lymphohistiocytosis, some features of cytokine release syndrome you see, for example, with CAR T therapy. There are features of thrombotic microangiopathy and so forth. So it's a new disease phenotype, a new syndrome, and we don't fully understand what's going on. You've heard earlier, and I'll stress, there have been some organizational challenges in the UK. There's been, I think it's fair to say, pandemic unpreparedness. I'll touch on that later on. Clearly, there were memories of the SARS outbreak in 2002, 2004, which didn't affect the UK, but there was this potential severe risk to healthcare workers. And in Toronto, up to a third of people who were affected were healthcare workers. And you've heard earlier about the challenges of, you know, when to do a lockdown. There are severe socioeconomic effects. You want to encourage herd immunity, but on the other hand, what's a socially acceptable number of deaths? And clearly the resource limitation of intensive care beds and ventilators, as was shown earlier by Mauricio in Brazil, the same applies in the UK. So for a developed nation, the UK, as you can see from this graph, doesn't have a huge resource of intensive care facilities. We have about 4,000 intensive care beds in the whole country. And a lot of the mitigation strategy scenarios were based upon availability of intensive care beds. You can see the red horizontal line is the surge capacity. So they reckon we could essentially double the number of beds, but clearly if you do nothing, the requirement for intensive care beds was modeled at being 25 to 30 times higher than we could currently manage. So clearly there's a problem. We did have some breathing space. So this timeline shows when different countries reached their first 100 confirmed cases. So in China, it was on the 20th of January. Italy, who are obviously badly affected, somewhere around the 24th of February. The UK around the 5th of March, and Brazil here on the 14th of March. So we had some time. We had a little bit of time to learn from China and to learn especially from the Lombardy region in Italy, and Milan in particular was very badly affected. However, I think as a criticism, I think lessons from China, from Italy weren't taken on board. And I think we could have been more proactive in learning how they were dealing with the outbreak. And we made the same mistakes. Italy made the same mistakes too. And it wasn't until the middle of March did the tone of the government change to, you know, from one of, well, it won't be much of a problem, to publicly accepting the fact that there was going to be many deaths in the UK. And then the following days, you know, the horror stories, the headlines started appearing. Most frail patients may not get critical care. A few days later, the virus will put 8 million Britons in hospital. And please remember, there are only 4,000 intensive care beds. So what happened? Well, essentially in China, they found approximately 10 to 15% of patients needing to come into hospital needed more than face mask oxygen. Patients who are more elderly with comorbidities presented first. The response in Wuhan in late January was early intubation and mechanical ventilation, and this very quickly overwhelmed their intensive care resources. In Lombardy, early March, they had the same problem, early intubation, mechanical ventilation. Again, they were quickly overwhelmed, and as I'll show you later on, that was the initial response in quite a few hospitals in London. Early intubation, mechanical ventilation, quickly overwhelmed intensive care resources. So you can see the same pattern repeating itself. And then we started getting these pictures back from Italy on the 21st of March. Italy in hell, Britain in weeks. All you can hear are sirens of the ambulances and church bells tolling for the dead. So we were being prepared for this apocalyptic vision of Italy being translated to the United Kingdom. Again, there wasn't much information coming out of China and Italy, and thankfully I've got some very nice colleagues, so I started badgering them with emails to find out what was going on and what their opinions were. And Dubin is, he's one of the heavy hitters in Chinese critical care. So whenever there's a major disaster in China, he's sent from Beijing by the government to lead the critical care response. And he was sent to Wuhan to lead the critical care response there. And I asked him several questions, and one of them was, are you allowing or forbidding non-invasive ventilation, high flow nasal oxygen? In the UK and in Italy too, there was this fear of healthcare worker infection. And he wrote back and he basically said, non-invasive ventilation, high flow nasal oxygen are everywhere. He agrees that there may be a high failure rate, and if you wait too long, that may eventually lead to the death of the patient. But he stressed the point that when you had hundreds of patients presenting with severe hypoxemia, often, as I mentioned earlier, with saturations below 80%, even with oxygen, you simply don't have enough resource for invasive mechanical ventilation. I asked him a further question, that we were getting advice in the UK to intubate patients requiring more than just 4 litres of oxygen a minute, which is, in my view, a little bit excessive. And he followed back saying, I don't have any idea where you got this suggestion. And he says, basically, wait until you either have severe hypoxemia and the patient is struggling. They're making big inspiratory efforts. So those were the patients you need to intubate. But if you can manage them on non-invasive ventilation, so much the better. I started asking my Italian colleagues, and they started sending me information. This is from Professor Pelosi in Genoa, in the Ligurian area in northwest Italy. And he sent me their little flowchart algorithm of how they manage patients. And you can see that CPAP came out in their algorithm. Sorry, and my computer's just frozen on me. I apologize. Hang on one second. I apologize. Let's just put it back to play. Yep. So CPAP featured strongly. And another friend of mine who was assigned to be one of the leaders of the regional emergency department response team in Lombardy, his name's Guido Bertolini, when I spoke to him, he said, look, I have no data, but I'm absolutely sure CPAP is the answer. So I took this on board and started asking lots of Italian colleagues in intensive care units in Milan, Rome, Florence, and so forth. And they told me how many patients they had in their hospital, how many in the intensive care unit being ventilated, and how many patients were receiving non-invasive ventilation either in or outside the intensive care unit, and many were. I asked if they were having problems with oxygen supply, because that is a potential issue. And most of them said no, except one in one old hospital, old building. What about the failure rate? Well, they thought about half needed to go on to invasive ventilation. However, that meant half were succeeding not to be ventilated. And especially if you have a shortage, you want to try and protect that very precious resource. How long were they needing to stay on a ventilator? And that was quite depressing. It was on average for a survivor somewhere between 12 to 14 days. So these patients with their very inflamed lungs were taking a long, long time to get off a ventilator, assuming they survived. And finally, I asked him a very important question. Are you aware of any healthcare workers looking after these patients coming to intensive care as a patient themselves? And basically the answer, like I was hearing from China, was no. They were wearing PPE, but they weren't getting healthcare worker infection. So at my hospital at University College London, which is in the centre of London, my colleagues bought into the idea that we should be going to CPAP, and our hospital chief executive also agreed. So we came up with this algorithm. The patients get an oxygen challenge, and depending on the response, their saturation, they went into a code red, amber, or yellow category. The red ones were the more severe ones. We tried them on CPAP. If within half an hour they weren't coping, we decided whether it was appropriate for them to be intubated and ventilated. The amber ones could go on to CPAP, and usually many of them tolerated it and improved. If not, they were considered for ventilation. And the yellow ones could be managed on oxygen alone. And clearly these patients were monitored, and you could move from one pathway to another. And this proved very successful. So we were able to increase the capacity outside the ICU to protect the ICU and the very sick patients who needed to be on a ventilator. And this initiative was led by our respiratory physicians. We worked very closely with them, and they basically trained up lots of doctors, nurses to cope with a big increase in CPAP use in our hospital. Other hospitals followed the rules, so we were a bit anarchic, but this is the following day. We instituted our protocol on the 20th of March. On the 21st of March, it's basically started exploding in London, and one hospital in northwest London actually had to declare a critical incident. They were overwhelmed with patients, and they lacked ventilators, they lacked critical care beds. And they, like many others, changed strategy and adopted this early approach of using CPAP, high flow nasal oxygen, to try and prevent many patients from going on to a ventilator. And also the National Health Service changed. So this is by the 26th of March, guidance was given out that yes, you could now consider using CPAP, but clearly don't let the patients get too tired and wait too long. And I completely agree with that. Just stressing the point about no issues of severe infection in healthcare workers looking after these patients. This is some data from our hospital. It's preliminary, so I wouldn't take it as absolutely accurate, but we've had 839 patients admitted to our hospital. 133 have been managed on CPAP, 28 of whom have progressed to mechanical ventilation. 32 of these patients died where CPAP was a ceiling of care. With their age, frailty, comorbidity, it wasn't considered appropriate for them to be intubated. 34 have gone home, 10 are still on CPAP, and 29 are improving. However, of 92 patients mechanically ventilated, 54, because we've had the capacity we've taken from smaller hospitals, 24 have died, only 7 have gone home, and 61 are still ventilated. So you can see if you can keep them off a ventilator, the turnover is much better, and clearly the outcomes are better too. This is a nice story. I won't dwell on it, but we didn't have many standalone CPAP devices. And so I was very fortunate to have brilliant engineers at University College London who had a very close relationship with the Mercedes Formula One team. This is a group in Northampton in the middle of England, and they build the engines for Mercedes Formula One cars. And they reverse engineered an old CPAP device, which has got no electrics, no alarms. It's just a simple wall CPAP oxygen flow generator that entrains air. And literally within a few days, they'd reverse engineered a perfect copy. We got it approved by the UK regulators. Mercedes have tweaked it. We trialed it on patients, and literally it's a month since we started, and Mercedes have now made 10,000 of these machines, which is hugely impressive. And I'm in awe of their skill and their talent and their application. And we're making this available as open source. So any legitimate body around the world has free access to the designs. This is from Brazil, and I know more than 25 groups in Brazil have accessed the designs and how to make the devices. And so we're hoping also to be able to send devices out to low middle income countries. Other points about management. Again, the Italians and the Chinese learn, and we've learned too, that proning the patient, turning them onto their bellies, actually improves oxygenation and helps their symptoms. And you can even start this early when they're awake. It's probably related more to better matching of perfusion and ventilation within the lung. Clearly, if they need ventilating, as I mentioned before, these patients often take a couple of weeks or longer, but daily proning is often effective. And the idea is to minimize the lung injury induced by the ventilator. So low tidal volumes, low levels of PEEP. What happens though, usually after about 4 to 5 days of mechanical ventilation, is that there's a very high incidence of renal failure, whether that's driven by the virus, the immune response, or as a complication of drying the patients out or the high airway pressures for ventilation. But some hospitals are reporting 30 to 40% of their patients needing renal replacement therapy. The lungs later become very stiff, and you get not only hypoxemia, but high carbon dioxide levels, and secondary infection, usually bacterial infection, can occur. I mentioned before about thrombi, and we're certainly seeing this, pulmonary emboli, arterial thrombi in legs, brain, etc., and sometimes bleeding from anticoagulation. So there's a debate as to how much anticoagulation, what anticoagulation should be given. Again, it's a new disease, we don't know the answer. Some patients develop hyperpyrexias to 40, even 41 degrees. Some develop shock, myocarditis, right ventricular dysfunction, encephalitis. So other issues are seen, but the predominant issue affects the lung. The last few slides, there have been major challenges. There has been an intermittent lack of appropriate personal protective equipment. This influx of patients, especially in the London area, there has been a shortage of intensive care ventilators and the consumable circuits. We're needing to use anesthetic machines, which are not ideal for long-term ventilation. A lack of non-invasive ventilators and the circuits, the kidney machines and the circuits, syringe drivers, drugs, sedative drugs, paralyzing drugs, anticoagulants, and crucially, a lack of staff. You know, the numbers have swollen dramatically, and clearly, you know, there aren't that many, it was touched on earlier, there aren't that many doctors and nurses with intensive care expertise. 20–25% of the staff are off. Either they've got COVID themselves or members of their family have got it and they've had to self-isolate. And this is having a very profound physical impact on the staff, in particular the nurses, who have to be there for hours on end wearing the heavy, horrible, sweaty PPE. And there's a major psychological effect, you know, looking after these very sick, often young patients. In terms of treatment, nothing yet has been shown to work. No antiviral treatment, and hundreds, and I kid you not, hundreds of adjunctive therapies, immunomodulatory agents, antithrombotic agents have been proposed. And these are just some of them. And there's a huge long list of drugs, devices, interventions that have all been suggested. However, we don't have any definitive evidence that any of these particularly benefit the patient. And clearly, you know, primum non nocere, first do no harm. Many of these drugs do have side effects, so we have to be careful about how we use these drugs. We've been trying to discourage compassionate use. We've had lots of different specialists all saying we should give anakinra, tocilizumab, plasmapheresis, etc., etc. And we're trying to encourage them not to go down this path, but to enter proper studies. And there are in the UK a few large randomized trials going on at the moment, randomized controlled trials and adaptive platform trials. So we need answers as to how best to treat this. We need, I would argue, a better understanding of the disease process so we can target therapy appropriately at the right time in the right patient. And so we need the biomarkers, the theranostics to treat appropriately. We don't understand why certain people seem to be targeted in particular. So adults versus children, particularly older adults, men to women, there's about a 2-to-1 ratio. We're seeing in London, I see the same in the United States, there's a disproportionate number of Black, Asian, and we're finding Orthodox Jewish people are affected. And generally, they tend to be more on the obese side with a history of hypertension and diabetes. I'll finish there, and thank you very much for listening. Obrigado.
Mervyn, thank you very much. It's fantastic. I was just about to stop you when you stopped. So fantastic. Thank you very much. I think people have found that absolutely fascinating and I mean, alarming, but really interesting and very impressive what you've managed to do, and fantastic. And also thank you for your honesty about what didn't go well. That's really important. So I think now I'm going to hand back to Rubens to introduce the next speakers.
Okay, I believe we have some time maybe for discussion, quick discussion, and then we go to the comments from the Brazilian speakers. Is this okay with you, Anne?
I'm very happy whichever way. I realise we've got a bit over time again. I'm sorry, I'm English, but I've gone wrong with the time. So if you want to go straight on to the Brazilian discussants and then finish off with what time we've got left, whichever you prefer.
Okay, is there any question? Yeah, is there any questions? Somebody will just raise their hand or anyway. Yeah, we have already some people here. But first of all, I want to congratulate all your speakers. And I think it's very important to recognize the importance of your national health system and how we really should be very proud of it. I know that there have been problems with budgets and a lot of political problems in the past, but England is an example of the whole world of how important it is to build this kind of system. And Brazil is trying to do the same now for many, many years. And our equivalent of our system, what we call SUS, S-U-S, is really being very important now. It's amazing that it's trying to take the best from the worst. At least, I believe, the society is understanding more the importance of science, the importance of scientific data, and the importance of have a basic health system, such important for the whole society. I have, I believe, some people ready intending to ask questions. Raise the hand, please.
Has asked to speak, Professor.
Okay, I'm going to ask, please, I'm going to ask first Arturo Fernandez, and I'm going to ask all of you, please, have very, very short questions and also short answers. Arturo, could you go ahead and identify yourself, please?
My name is Arturo Fernandez Cruz. I'm professor of medicine at Complutense University of Madrid. My area is the prevention of chronic diseases. And I'm really amazed to begin with and astonished about all the data that you put together in this program. And I really congratulate most of the speakers for their presentation. But I must say, as a Spaniard, living in the center of these tremendous and colossal problem that we have facing the virus, that I could be as mad as hell. And I can say, even I cannot take it anymore. And the question is addressed to the testing procedure and how we're gonna handle, particularly after lockdown, to guarantee that you're gonna be able to sit down nearby another person, either in the theater or taking a drink, and you guarantee you will not be infected. This is a very crucial point, which is something that is interesting for our country at this very moment. And thank you so much for your attention. Thank you a lot.
Who would like to answer this question? One of the speakers would like to address this question?
Probably
Dr.
Maria.
Caesar? And maybe I'll ask you a quick question so you can ask. So I understand that you are not using none of the drugs you mentioned for compassionate use. You're not using chloroquine, you're not using antibiotics unless they are under strict protocols in the hospital. You're talking about patients in intensive care unit. How about patients that are positive and start to get pulmonary symptoms? Do you have any protocol on that? Thank you very much.
Yeah, well, again, we're trying to do it within trials. As I mentioned, there are some large randomized trials going on in the UK, and so we're trying to adhere to those. And chloroquine is one of them. I believe in the next few days, there's a New England Journal paper coming out showing chloroquine isn't effective. I haven't seen the paper, but I've heard. But so we're trying, there are antivirals being tested, tocilizumab, etc. So we're trying to keep within a research structure. What we're doing with anticoagulation, we're taking a halfway house. We're using high dose prophylactic. And if the patient clearly has obvious thromboembolism, then we're going to full anticoagulation using enoxaparin, low molecular weight heparin. There are groups trialing TPA, argabactan, thrombin inhibitors, clopidogrel, etc. So there's lots of people trialing different things, but again, we're trying to do it in a structured manner.
Thank you very much. Well, we're going to the people that has raised a hand here. I have Daniel Tabak first, and then academician Aderbal Sabra. Daniel Tabak, please.
Thank you, Mr. President. Appreciate very much your talk, Dr. Singer. My question for you is some kind of pathophysiology. I mean, this is kind of weird regarding the symptoms of the patients that they got so much hypoxemia and they feel very comfortable. And I wonder what the explanation for that. And also, if there is this difference on pronation, you have a lot of the patients with ARDS that this is not really exactly something that really relieves a thing. And I've read some reports that some patients that actually by pronation didn't have to go to the tube, didn't have to be intubated and go in the vents. I just wonder if you give some information about that. Thank you.
Thank you very much. Yeah, again, fascinating disease. The theory about why patients tolerate these very low levels of oxygen saturation, the one I like the best, there's been some early work, like there was a paper in Cell about the ACE2, which seems to be depleted. And apparently ACE2 is also quite heavily expressed in the carotid body. And so that apparently may be relevant for why the patient doesn't recognize hypoxemia. So I think that's quite an attractive theory. the reason why patients, why they get this hypoxemia, it's not so much atelectasis in the first instance. These lungs are not collapsed down, but they're not being ventilated adequately, but there appears to be hyperperfusion of blood vessels, so you have a very large shunt. And an Italian group's measured this, and the shunt fraction is about 50%, so this is huge. And the CPAP or pronation, awake pronation, improves that. And so that's why, and I mentioned this in my talk, you know, we're trying, like the Chinese and the Italians have found, awake pronation improves this ventilation perfusion mismatch in the lung, improving oxygenation, improving patient symptomaticity, and stops them getting tired and hopefully stops them needing intubation. You're welcome.
Thank you so much. Dr. Singer, rain check. You will have many drinks on us next time you come to Brazil. You've been very good and very useful to all of us. Professor Academician Sabra, please.
Thank you very much for all the talks, but I have a special question for Dr. Singer. The physiopathology of the virus diseases has a lot of news and well-known situation, like the virus has a protein that blocks the immune system. And between the innate and adequate immune response, you have a storm of cytokines. The lung is the major problem in the patient. And we can realize from the pathology that we have at least 4 different times. In the beginning, the virus blocking the immune system, devastating all the cells. And after that, they start a secretion of collagen, and the pneumonia established after that. My question is, why we have to wait the hepatizations of pneumonia situations? Why don't we act before, in the beginning of pneumonia, using like medications for hyaline membrane, like we do with children and newborns, starting very early to treat the disease, not waiting the time when the disease and the storm of cytokines is a mess. And the hepatization is very hard, as you showed to us, a beautiful experience. Why don't we treat pneumonia in the beginning, going fast after the first 2 stages of the immunopathological modifications? Thank you.
No, thank you. That's a great question. I think the problem is that patients don't, and I think as Maria showed, they don't often present until a week, 10 days into the illness. So often by the time they present, they're often relatively advanced in their disease process. And I completely agree with you that, and again, I think a lot of the therapies need to be started before they're on a ventilator. But you have this sort of quandary. We know that many patients, 80–85% of patients who come into hospital will get better without needing anything more than face mask oxygen. And so you don't want to give a treatment to them that could harm them. So ideally, you want to pick out the patients who are likely to deteriorate. And I agree with you, if you can intervene before they need to be intubated, ventilated, and have all of the other problems, that would be the ideal. And certainly, I 100% adhere to your proposed strategy. You know, you want to leave the ones who will recover quickly alone and focus your attention on the ones you predict will do badly.
Thank you very much.
Thank you.
Thank you. We have now Academician Manassés, I believe, willing to say some words. Manassés, do you hear me?
Manassés is having some trouble logging into the room. I'm trying to help him.
So in the meantime, Is there anybody else who are willing to make a question, ask questions?
We have a question from the chat.
Go ahead. I don't see it. Go ahead.
It's from Maria Clarice Alves. She says, hello, I'm a medical student from Brazil and I have a question. Do you think it is effective or promising to use hydroxychloroquine as a prophylaxis for COVID-19, as some countries like India are doing?
I think potentially yes. The data on hydroxychloroquine is mainly, from my reading, mainly related to mouse studies and some in vitro studies. So there was a bit of sporadic use with H1N1 and with SARS, but again, no good trial data. But I think potentially as a prophylactic, it may be effective. I think, and I mentioned earlier that there's this New England Journal paper coming out looking at giving it after hospitalization, and it apparently hasn't shown any benefit. I think potentially there are some antiviral effects if you get there early enough. But again, it needs a trial.
Thank you so much. We are still waiting for Academician Manasseh, so I believe there are no other people willing to make questions right now.
Professor Miguel Orion has raised his hand.
Oh, I'm sorry. Go ahead and allow him, please. I don't see him. Go ahead.
Thank you very much. One piece of data, Mervyn, the trials from hydrochloroquine come basically from the French group that used it first in 20 and then in 80 individuals and showed a reduction basically in PCR quantification during the first days. So that's the only real data that I've seen so far. Not sure where it's going to go. And the question to you is, we see clearly, even in young individuals, some that have, without clear comorbidities, some that have, the benign, and the others that have the severe form. And then the question is, why, where is the issue? It reminds me sometimes of dengue 1 and 2. It's like maybe there are people that have pre-existing antibodies maybe to another coronavirus, and those have the severe form and others do not. Thoughts on that?
Yeah, no, thank you, Miguel. Yeah, I think great question. I highlighted in my talk, we've got these communities, the Black Asian groups, Orthodox Jews, and there's something about them, but we're not seeing it in children. So there's probably a genetic component. There's almost certainly an epigenetic component. And again, there's a big study going on in the UK to collect a lot of DNA, so transcriptomic DNA, to be able to actually better understand the genetics and why some people are more susceptible than others. And there may be other factors. So socially deprived, we were hearing about people who live close together. There's a theory that vitamin D may be relevant. So these people may, because of the color of their skin or living in closed communities or wearing lots of clothing, may be vitamin D deficient. And the UK, unlike Brazil, we don't get the sunshine you get. So there are lots of different theories. One theory I've heard is that Africa's not suffering so much because of the sunshine. Again, lots of interesting theories.
Right. Okay, great. Thanks.
Thank you very much. I have some questions I received. Any indication for chest X-ray? You go for chest CT, and when and how?
My personal view, it depends, A, on the logistics of your hospital, and B, again, the severity of illness of the patient. So if they're very unstable, is the CT going to make a big difference to your management? I think if you're worried about pulmonary embolus, it's worth doing. I think what we're doing, if we're seeing evidence of deep venous thrombosis by ultrasound, and the patient has a severe lung deterioration, we're using that as a proxy that they may have a pulmonary embolus. But if the patient's stable enough, and as I mentioned before, they can be incredibly unstable, if they're stable enough, we will take them for a CT scan, especially to do a pulmonary angiogram.
Thank you. And now talking about the healthcare team, prophylaxis for them, any specific prophylaxis for people working at a very contagious environment? And second question, any recommendation for women that get pregnant and still work in this environment?
Well, again, we're not taking any prophylaxis. I think in China, some places were taking hydroxychloroquine, but certainly not in the UK. There's no healthcare worker taking anything that I'm aware of. What we're doing is nurses who are pregnant, nurses who may have some immunosuppressive type of illness, we're keeping them away from the front line. So they're doing administrative duties or looking after non-COVID patients.
Thank you. Okay, I believe we have academician Celso Ramos ready to talk and make some comments. Celso is being a key leader in this fight here in Brazil, and he's been serving the Academy and many body organisms with his expertise, and he's put a lot of his own health on that. So Celso, go ahead, and thank you very much.
Well, thank you, President Dufour. This has been a very exciting experience. I would like to present my compliments to Dame Professor Anne. It's the first time I ever spoke to a member of the Order of the British Empire, so I'm honored by that. And it's really extraordinary having so many people speaking about this dire situation we're in. I would like, yes, to make a few questions. First, about epidemiology. Epidemiology is not an end in itself. Epidemiology serves us to prepare to face an epidemic or to prevent diseases. And we are, in a sense, trying to find what's happening even before it's happening, which is, of course, very difficult, if not impossible. I am intrigued by certain features in Brazil. Brazil was compared to the UK in terms of area, of course, by our first speaker, I believe, Professor Edelstein. Well, actually, it's more than that. Bahia, the state from which Professor Barreto is speaking, is larger than France. Minas Gerais is larger than England. The tiniest state of Brazil, Sergipe, is larger than El Salvador. And the city of Rio de Janeiro is larger than Singapore. Of course, with the exception perhaps of Sergipe and El Salvador, we are very much poorer. So it makes things very different, very difficult. Now, what I mean by this is that we cannot consider, at this point in time, we should not consider Brazil as a whole. There are too many different ways the epidemic is behaving. I am intrigued by 2 or 3 things. First, Fortaleza, or even Ceará, but Fortaleza up in the northeast is one of the places, perhaps the place that is most attacked at the moment. Why is that happening? Second, Amapá, up in the north, almost in the northern hemisphere, is also, with a Chinese state, is also already under very strong stress. And Manaus, of course, whom everybody knows as one of the 2 capitals. There's no one from Belém hearing, I understand, but one of the 2 capitals of the Brazilian Amazon. I wonder if this does not relate to, at least in Fortaleza and Manaus, relate actually to the winter holidays in Europe. I believe from my experience with HIV epidemiology, I know that in Fortaleza, there is a tremendous amount of sexual tourism coming mostly or especially, or at least in a great part, from Italy. And I wonder if this is what started the epidemic there. Manaus, of course, is in the heart of the Amazon, is a place to go nowadays, so it would need no explanation. But Amapá is so small, is so away from the rest of Brazil, it's actually difficult to get there, that I wonder if the epidemic there did not start by people coming and going into French Guiana, which is just across the border, which is just across a river. This is one thing. Also, I think that while we think of Brazil as a whole, we tend to mingle, to mix up, to make a bundle of many different situations. If you consider, for instance, just Rio, if you consider what's happening in Rio, the capital, you do not actually know what's happening in the outskirts of Rio, and you do not know what's happening in the smaller cities and smaller municipalities in the state, where nothing perhaps is happening at the moment. So I don't know if Professor Barreto would like to speak later on this question of mine. I would like also to consider or to address the question of testing. I think that in the press as a whole, and even among many physicians, people do not know what is actually being meant by the famous phrase from Dr. Tedros Adhanom, test, test, test. This does not mean indiscriminate testing. This means actually contact tracing, as Dr. Edelstein mentioned, which is something that I do not think we're doing in Brazil. I do not think we will be doing in Brazil. And I do not think that we've ever done in a large scale, at least. So we tend to fall down or over into diagnostic testing, which is a different thing, very different thing altogether, as was shown. I think Professor Barsinski will probably delve into this matter more thoroughly and with much better knowledge than I. But I'm intrigued by some results of 8 antibody tests I've seen with people having just been infected. Of course, it couldn't be otherwise. Having tests reactive to IgG antibody and non-reactive to IgM antibody. I wonder if that's real. I mean, if these people are just mounting an IgG response and not an IgM response, as I would expect, or if this is actually the result of former infections with other coronaviruses, especially with endemic alpha coronaviruses. And there is another thing that I would like to address, and that is the social response, not by the community as a whole, not of the individuals as individuals, but as individuals of some politicians. I'm not referring to anyone in particular. I do not have anyone in mind, especially. But we all know that in epidemics, and again, coming back from the HIV epidemic in Brazil and elsewhere, we have a very large amount of negation initially, and people tend to take time in order to observe that the problem is actually within ourselves, actually in our middle. I would recall Edgar Allan Poe's Gothic short story, The Mask of the Red Death. So we tend to negate, we tend to say that, no, this is not going to happen here. This is not going to happen the way people are predicting. And then we fell hard on our bottoms, on the bottom of the earth. This is happening, this has happened in many places. And I hope the fall is not very hard in some countries, like Brazil. Thank you very much, Mr. President.
Thank you very much.
Sorry. There is one other question I would like to address. A very chatty young lady, a student of medicine, Dr. Clarice, has asked about the use of hydroxychloroquine as a prophylactic. Well, chloroquine itself has been used as mass prophylactics, especially in the Amazon, back in the 40s and 50s, last century, in something that was called the Pinochet method, using against malaria. They would mix chloroquine with table salt, and people would get salt and therefore get chloroquine. That was effective in some places, especially at the then British Guyana nowadays. But I don't think it would be feasible, it would be acceptable to use hydroxychloroquine at the population level. And besides that, it has not been proven to be effective, and it would be unwise, to say the least, to propose a public policy of such large extent, of such large cost, however cheap single tablet may be, when we have so little proof, if any at all, of its effectiveness. Thank you.
Thank you very much. Thank you very much, Celso. Always running against time. We have Carlos Alberto Barros Franco here, one of our academicians, also with large experience in the field. And we have also academician Manassés ready to talk. We do have 5 minutes for everything. So, Carlos Alberto Barros Franco, why don't you start, please?
Hello. Hello, good morning. I apologize, I arrived late because I confused the time from Brazil and London. And so I'm a pulmonologist and I treat a lot of patients with the COVID disease. And we have a lot of doubts. So I think I would like to make more questions than to give my experience. And the question we'd like to hear is, first, in London, in England at all, what kind of drugs are you using to treat the patients hospitalized outside the ICU and ICU patients? The second doubt that we are discussing a lot in Brazil is what kind of ventilation we offer for these patients. In the beginning, the indication was to make an endotracheal intubation in the first time. But now usually you are beginning to treat these patients in non-invasive artificial ventilation. So I would like to know how is the experience and the routine used in England. The third the important things for everything is what is the criteria to discharge the patient from the ICU to an intermediate area or a room without risk to infect another one. Sometimes use the time, 14 or 21 days. Other use the PCR to identify if you have RNA of a virus. So what criteria do you use when a patient that leaves the artificial ventilation to go to room?
Thank you.
We have another, the last one, very, very fast. The last one is the identification of fibrosis, pulmonary fibrosis, late in the treatment of the serious pulmonary disease for COVID-19.
Thank you, Carlos Alberto. Maybe you should, who would you like to answer these comments and have some answers to these questions? Would you like to reply to this? Yeah, go ahead, please, Dr. Singer. How to say your name, Singer or Singer?
Singer.
I'm sorry, Dr. Singer, please, go ahead.
Not at all. No, very briefly, again, I described CPAP, and again, that's a strategy that we and many other hospitals have found very successful in keeping lots of people off ventilators. I think, unfortunately for the United States, I think I mentioned it, that the FDA didn't advise it because of this fear of healthcare worker infection. And you can see on the news what's happening in New York, you know, where they're sadly having to bury bodies in Central Park and whatever. So I think, you know, that strategy is well worth looking at. And I know from colleagues in Brazil that it is actually being used in some places, certainly in Brazil. As I mentioned in my talk, we're not doing anything outside trials. So there are trials going on of antivirals, of steroids, of hydroxychloroquine, etc. We're using steroids in some of our intensive care patients in the later phase when they have a very sort of severe sort of cytokine storm type of approach. So when they're getting very high D-dimers, very high ferritins, and some of these patients do improve. Not all, some do. Again, it's the same issue with the fibrosis and the lung disease. So we're not using any specific anti-fibrotic agent on the lung or for the lung fibrosis, but again, just like ARDS, some people do respond very well to steroids with improvements in gas exchange.
Thank you so much. Well, before passing the word and the chairmanship to Professor Ann Johnson, I have Academician Manassés here, and maybe he could address now us for a few minutes before we close. We are at 4 minutes for everything. Manassés, go ahead.
Thank you very much, President. This virus is a fabric of two substances, protein, nucleic acids, and also cofactors for enzymatic systems. Because of that, there is a possibility that they can leave a trail after everything is treated. And I think people should look for the future, because pressure in the lung around between 5 and 6 millimeters of mercury. In some cases, some people get sick and die because this rises from 5, 6 to 80 to 90. So we should see if there is a residual pulmonary hypertension that sometimes damages also the heart, and then you are with a double disease. With this in mind, we can see that it's necessary to prepare for the second phase. That's why I called the day after, because I believe that many people are continuing with high blood pressure, like they have demonstrated recently in Italy and also in China, and perhaps in other countries that were not really worked with more deepness in this fact. So we should never forget that the small pressure that the lungs were very much studied during the first 30 years would be transformed in a nightmare, and we have people for many, many weeks, perhaps even die as a consequence of this. Here with, in our academy, we believe that we already did this because it was here by the first time that Professor Paulo Saldiva made a seminal observation. Many people didn't talk much about that, but I was very impressed because Saldiva was the only one that made the study of these people that died from the point of view of the physiopathology. So that is one point that could bring about many new knowledge that could be very important for the future of the treatments of things like that. So we believe that's very important that we think for the day after, and we prepare some communities to be following up these patients that survived but will continue sick. That's my point of view that I wanted to display this afternoon.
Dr. Singer, thank you, Dr. Singer. I do have a last question for you. It just came. Could you elaborate a little bit about encephalitis in your experience? I know there's been reported some necrotic lesions in the brain, but besides that, what's your experience, your feeling about chronic neurological disease?
Yeah. We've in fact had one patient who was very confused, and we did a scan of her brain, and she did have swollen brain, and again the presumption was that she had an encephalopathy. Clearly, I think one of the problems with, like any critically ill patient who's been in intensive care for weeks, they often get long-term psychological, cognitive, physical problems, and that might be related to the disease process, tissue hypoxia, cytokines, and obviously the effects of all the drugs and intervention. So I have a real fear that the survivors who are critically ill may have very severe long-term problems, not just with lung function, but cognitively and physically.
Mm.
Okay, well, I want again to express my gratitude, not only for our friends from the United Kingdom, but also the Latin American and the Spanish Academies of Medicine. And specifically, even with all the problems that Venezuela is having, we have Dr. Medina and Dr. Razabet with us. Dr. Ryan from Chile already spoke, and we had a lot of support from Colombia, Dr. Toro Ocampo and Dr. Gabriel Carrasquilla, who sent us a very nice chat message. Argentina, we have Professor Robert Schwitt among us, and also the only woman president so far from Latin American Academy of Medicine. We had Dr. Graciela Lago, president of the Uruguayan Academy of Medicine. So thank you again, everybody. I will pass the word to Professor Ann Johnson to close the meeting.
Thank you very much, President Belfort. I would like to thank you all for incredible participation. This was an experiment for both of our academies, and I was just delighted to see so many participants and to see that nearly everybody's here right to the end. And it's been a fantastic collaboration between us. I can't thank the speakers enough for giving up their time. I know how incredibly busy everybody is. I particularly wanted to thank Roberta from the Brazilian Academy and the team from the UK Academy, Liz, Abby, and Alex, for all the work that they put into putting this together. And we have, I think, really enjoyed doing this. We would welcome your feedback on this as a first experiment. We hope we may be able to follow up with you in a number of ways on some of the ideas that you've heard about. You've heard Professor Singer talk about work on CPAP and developing technologies that could be rolled out at scale to other countries. You've heard Maria Zambon talk about diagnostics and how we must all work together to improve those and be able to deliver them at scale. We're all learning very, very fast. And for me, I've learned a great deal from colleagues around the world today. I hope you've all learned. I hope we continue our collaboration. And it's really wonderful for me to work in Latin America. I learned about public health first in Latin America, in Venezuela in the 1970s. And I always love to be working with Latin American colleagues. I apologize that my Spanish is rusty and my Portuguese is virtually non-existent. But obrigado and have a good day. And I hope we continue to work together. Hasta luego.
We plan to organize a Latin American meeting in a few weeks. And we're going to invite the academies from Latin America, as well as maybe some countries of Portuguese-speaking countries from Africa, to discuss specific items of the agenda. And we'd love to have United Kingdom Academy of Medical Science among us for that opportunity also. Thank you very much to all of you. And for the Brazilians, we have our regular session in 1 hour at 6 o'clock. And thank you very much to everybody. Bye-bye.
Bye-bye.
Foi bom. Foi.
We have now the microphone open, so if anybody that wants to talk, please feel free to do it. It's what we call T electronic time. So just go ahead. I'm going to have a glass of water. I come back soon.
Agora eu estou antenado aqui, mas também só ele mesmo faria isso comigo.
Está lá, aqui eu já desliguei.
Mas eu citei as duas coisas principais.
Daqui tu bota aqui, tu ainda pega. Tem esse daqui conversando aqui, que eu não sei o que é. Parece que é aquele cara da Globo Music, que já agora vai pegar fogo. Ixi, desliga aí, filha. Nós estamos falando e está aí, viu? Eu já
Se não lugar escrito sair.
Hã?
Se não lugar escrito sair.
Não saiu.
O clima quase de terror se instalou no meio da população. Isso não é bom. Uma pessoa que vive sob tensão, um clima de histeria, uma pessoa que está sofrendo por perigo. Nova doença, ou agravar já na sua cabeça. Entendemos que toda é a gravidade da situação. Gostaríamos que ninguém perdesse a vida, não só Toca todos nós.